Let's give it just a couple more minutes. We got folks that are getting seated, and then we'll begin. Okay. Good morning, everybody. Good to be here. I want to call our meeting to order and welcome everyone to the second meeting of the Georgia House Study Committee on Certificate of Need Modernization. And I want to tell y'all up front, I don't feel comfortable sitting here with my back to everybody. I don't know about y'all, but anyway, we'll do the best that we can. I'm Butch Parrish, and I want to thank Speaker Burns for allowing me to chair the special committee and for appointing members who have clearly been chosen for their expertise in their legislative knowledge and their real world experience and overall in-depth thoughtfulness. And I'm going to ask that we just go around the room and let everyone do a little self-introduction, if you would. And Mike, we'll just start with you. And to speak, you need to touch the speak button on your console there, and that turns it on and off.
I'm State Representative Mike Cameron. I represent the 1st District of Georgia in the Northwest corner, which includes most of Walker County and all of Dade. It's mostly rural. My background is I spent 32 years in the health insurance industry working on Medicare policy and things like that. So that's where I bring my expertise to the table. Thank you.
Good morning, Valerie Montgomery Rice. I am the president and CEO of Morehouse School of Medicine, and I am a reproductive endocrinologist and fertility specialist by training, OBGYN also. And I bring expertise from a lot of different perspectives, and hopefully the one that will resonate the most is that we want to make sure that everybody has access to care and can live out their optimal level of health.
Good morning. I'm Lisa Hagan, representative from House District 156, which is all or part of 6 counties in South Georgia between Macon and Savannah. And being someone who is not professionally a part of the healthcare industry, this is a mind stretcher for me, especially at 9 o'clock on a Tuesday morning. But I look forward to hearing from everybody who's here to share some wisdom and expertise with us this morning. Thank you.
Good morning. My name is Lee Hawkins. I'm a retired dentist from Gainesville, Georgia. I represent the 27th District. I have been in the legislature now about 17 years, so I'm still learning. I learn something new every day and look forward to listening to the testimony today and learning about your issues even more today. Thank you.
Representative Mark Newton. I represent District 127, which includes the Somerville area, part of the campus, and then all the way out into Evans, Georgia. So a local guy who had the shortest commute in today. Thank you for all those who came from a lot further away. I am an emergency physician, is what I do for a living, and I also have some urgent care centers. So my whole professional medical life has been in the hospitals, and in a hospital that is a fully fledged hospital with all the challenges and advantages and benefits, but also out there in a private practice area. So I look forward to hearing from everyone, is seeing how we can make things better in Georgia, including in particular access and affordability.
Good morning. I'm James Beverly, the minority leader for the Georgia House. I'm an optometrist by trade. I have a couple practices in Macon, Georgia. One that serves pediatric kids and the other one glaucoma. And so looking forward to the conversation.
Good morning. I'm Debbie Mead. I am from Middle Georgia. I have health management. I'm a small independent owner. I have been in long-term care for 35 years. I serve on the Georgia Healthcare Association. I've been on that board for 28 years. I've chaired the American Healthcare Association. Looking very much forward to our education today and learning more and helping with the CON need.
Good morning, Scott Rains, President, CEO of Southeast Georgia Health System in Brunswick, Georgia. Honored and pleasure to be a part of this. Thank you.
Thank you. We're very fortunate to have all these folks with us today. We've got an outstanding committee here. And we have another team that's I think is the A team and outstanding as well. Tara Buckhalt right here in our House Budget and Information office over there. She is assigned to our committee and just does an outstanding job dealing with healthcare. Betsy Howerton is legislative counsel. She's around here somewhere. Raise your hand, Betsy. There you are. And then Haley Delisle from the Speaker's office. Glad to have you with us. And Camille and Justin from the House Information. Thank you for helping us keep us running. And then Ivy Birch, who's in my office in Atlanta. And I want to thank everybody in the audience for coming. I really wish I could turn around and talk to you, but we're glad that you're here, and we'll work on that for later. Before we move into our agenda, I want to recognize Augusta University and thank them for helping to make this meeting possible today and hosting us here. So President Keel is not with us today, but Vice President Keene is here. Margie Miller, Ashton Blakeman, Luke Ray, who were with us yesterday, helped us get on target, are here. But at this time, I'd like to ask Russell Keene, Dr. Keene, to come up and welcome us from the university. Russell.
Mr. Chairman, distinguished members of the committee, guests here today, welcome to LA, lovely Augusta. We're glad you're here. Augusta University is home to the state's only public academic medical center. You've invested in this. Your colleagues that came before you have invested in Augusta University, in the Medical College of Georgia. And we are home to the Medical College of Georgia, the Dental College of Georgia, the Georgia Cyber Center, the Georgia Cancer Center, the Children's Hospital, Roosevelt Warm Springs Rehabilitation, and a number of other unique attributes that make Augusta University special. We know that we would not be the institution that we are today without the support of each of you. We know that healthcare is a big problem that this state is facing, and the decisions that you all are grappling with have broad implications. We appreciate your continued consideration for academic medical centers, but particularly with the medical college and all that we have here in Augusta. So we welcome you with open arms, whether you're meeting officially or not. I will say before, our president, Brooks Keel, is deeply regrets not being here. However, he had some alternative trips planned that he could not change. And I'll just say we're grateful for your continued support, and we stand ready to help you in any way. So thank you, sir.
Thank you, Russell. We're glad to be here. Some of my remarks today will be a repeat of the remarks that I made at our first meeting, this being our second, because I know that some of you that are here with us today were not at the first meeting, and I think it's good to give just a brief background on CON and how we got to where we are today. Today, in response to House Resolution 603 that was passed in March, we begin the second of our 4 planned hearings on Certificate of Need modernization. And some of you might ask, well, why modernization? And as many of you know, CON was first mandated by the federal government in 1974 and was shortly thereafter adopted by Georgia and all the other states. The feds repealed the mandate in 1986, and subsequently the 50 states have gone their separate ways in either repealing, amending, or continuing the CON regulations. And indeed, Georgia has since modified its regulations several times, but given the rapid evolution of healthcare in this country, I think it's wholly appropriate that we now investigate the structure and regime best able to provide Georgians with cutting-edge healthcare that's both accessible and affordable. As Speaker Burns has articulated on many occasions, moving healthcare forward in Georgia is one of his top priorities. This study committee is intended to be a vehicle that will move us all in the same general direction, making improvements, clarifying ambiguities, and putting behind us as many roadblocks as possible. I want to be very clear that we do not come to the sequence of hearings with our minds made up about what the future of CON is. We will rely on no preconceived notions. We do want to hear about the issues, the problems, and the concerns, but our focus needs to be on discovering the solution to these complaints. We want our eventual recommendations to be based on facts, evidence, and fairness. And I don't have to tell you in this room that healthcare is a complex subject. What we do want to do is study the issues and the opinions from every point of view, which includes holding meetings in Atlanta, Augusta, and Albany to ensure full consideration of various situational perspectives. Our final meeting in October will be held in Atlanta, October the 10th. And my expectation is this committee will subsequently produce recommendations that can be drafted into legislative remedies that encourage providers to offer preeminent health care, whether it be routine, emergent, or traumatic, that's more affordable and increasingly accessible. And now I think it's time, let's move into our agenda. And the first item on our agenda will be Chris Denson with the Georgia Public Policy Foundation. So Chris, come up and take the podium and identify yourself, please, sir.
Good morning. Good morning. My name is Chris Denson. I am the Director of Policy and Research for the Georgia Public Policy Foundation. We're a nonprofit think tank located in Atlanta, focused on state policy issues. And I'm here today to present on the report that we published in April of this year, and which we examined the history and the economic impact of certificate of need laws in the state of Georgia. And I'm just going to walk you through the report, do a brief overview. Everyone should have a copy of it in front of them, along with two handouts that I've inserted in there that I'll explain both as this process is going on. And, this is a subject, Chairman Parrish mentioned the history of the subject, and it seems to be continually ongoing. Of course, both our neighbors, North Carolina and South Carolina, have enacted CON reforms since the publication of this document. I know that the presenter from NCSL spoke about this a little bit at the last meeting, but there's some other things as well I'd like to highlight in relation to Georgia. But anyway, so let me get started here. And so, the overview, or what we look, sorry, my apologies. This is a tight fit here for paper documents. So we wanted to look at the issues surrounding cost, access, and quality of healthcare as it relates to CON. And so my co-author and I, Dr. Matthew Mitchell, who's an economist that's affiliated with West Virginia University, he takes a regular look at the existing academic research around CON. And so if you later on in the study, I'll provide a brief overview. We've summarized those studies, what they show regarding healthcare spending, access, quality, the ability for underserved populations to access healthcare in states with and without CON, underserved populations being traditionally those in economically depressed areas or ones that have provider shortages. And so with that, I'll get started. As Chairman Parrish noted, I'm going to skip over the legislative history here in Georgia, but if you go to page 9, we did summarize all of those reforms since CON's enactment in the state. The year, what was done to traditionally, in almost every instance, lessen the CON regulations that the state currently had in place. And so you'll see here, even in that setting, we've included what previous speakers have mentioned those committees, including a Georgia State report going back to 2005 when Governor Perdue established the commission. And just if we just want to make it an easy access point for anyone that wants to go back and look at the history and the evolution of CON laws in the state of Georgia at that time. On page 12, we've outlined what it takes to receive a certificate of need in Georgia, the process through which you go through the Department of Community Health. I know you heard it from DCH at the last meeting, so I won't go through that. This is where I do want to, and we've listed obviously here every service that requires a CON in the state of Georgia. But this is where I want to reference my first handout. I had the opportunity to speak at an event that the Atlanta Regional Commission hosted a few weeks back, in which they looked at healthcare disparities resulting from the closure of the two Wellstar hospitals in South Fulton. And if you'll notice here, and I apologize, it was supposed to print in color, but it's here in shades of black and white. But if you look at where behavioral health and urgent care enter the patient care continuum spectrum, there are 14 different services that were impacted by the closure of those two hospitals. Of those services, 11 of those require a certificate of need. So that's something that to think about whenever we think about, okay, a hospital is closed and we need to replace those services. This is what we need to do in terms of allowing for replacement, whether it's a single individual hospital or a multitude of facilities or services that will do that. But I was speaking with Dr. Rochelle afterwards, and she's the chief health officer for Fulton County, and she'll give me permission to share that slide with y'all today. I know at the last hearing, there was some discussion surrounding the application process to receive a certificate of need at the state. My team and I, we researched every application from 2017 to 2022. As you'll see there, that was nearly 380 certificate of need applications. When we went to publication, 43 of those were still outstanding. But of those we reviewed, we found that when there is an objection to a certificate of need application at the state level, the odds of denial more than double from 20% to about 50%. Every additional party, so in some cases, when you have opposition to a CON application, that increases the odds of denial by roughly 11% with each opposition that is proposed to a CON application. An opposition that's filed to a CON application adds 234 days to the wait time. But if it's specifically a competitor opposition, that adds 520 days to the wait time. Each additional party on top of that adds another 129 days. And then here are these last 2 points that we found in our research. The cost of the project is not statistically significantly related to either approval or wait time. So when we think about what type of project it is that the application is for, there was no bearing in terms of cost on the approval process. And then there was not any statistically significant trends in either approval or wait time in the overall process. So what we wanted to do was just provide an outline there of the complexity and the duration of time that is required when a CON application process is begun, especially as we look at closures, evolution of healthcare technology, and how do we move forward in ensuring healthcare access in our communities. One thing that I know many members of this committee have looked at, many deal with this in their own communities, is what is the impact of certificate of need laws on safety net hospitals? And so, we often hear this argument that CON is needed to protect hospitals, most specifically in terms of elective surgeries and imaging, the two revenue generating service lines. And so, the CON should be needed for their protection and sustainability for these safety net hospitals, which are most often in rural areas. And so for this study, we examined Florida, which repealed CON laws for everything but specialty hospitals and long-term care facilities in 2019. And during that time, they have announced 64 ambulatory surgery centers opening, where elective outpatient surgeries are held. And in that area, 63 of those were located in urban counties. Only one of those actually operated and located in a rural county. The full appendix of those openings is in the back. But what's interesting about that one rural county, it was actually a joint venture between the local hospital in Florida and a physician group. And then there was another physician group in a neighboring county that announced their own plans to open an ASC. So we did see this kind of add-on effect of providers were coming to this area. But that's just, I think, instructive for when you think about the safety net hospitals and where these elective surgery centers might be located. On page 17, you'll see a chart that we compiled. I believe we now have 13 states since South Carolina that have repealed their certificate of need laws for nearly everything. And that chart there in front of you compares Georgia to similar states on page 17 in terms of population. So they're ranked by population, but also by the percentage of rural population as well. And so we use the documentation provided by the Shep Center at North Carolina, compiled since 2005 to look at rural hospital closures. And what you'll see there is we've actually, the two states that are most geographically similar to Georgia, the state most geographically similar to Georgia, North Carolina, actually has a CON for hospitals and ambulatory surgery centers, and has had the most rural hospital closures in the time period we examined. And so that's just another data point when looking at the impact of CON on safety net hospitals and what it means if we have a CON law and the ability to sustain our rural safety net providers. On page 18, we move into the summary of the academic research. As I mentioned, we looked at spending, we looked at access, we looked at quality, and we looked at underserved populations. If you look there, there's tables that summarize the data and the research in there. And in the back as well, we also have an appendix that cites every study we've looked at in case you want to do a deep dive into that. But what you'll overall see there is that, for example, on spending, that CON is 60% of tests we examined was associated with worse spending outcomes. That's on page 22 that summarizes the spending data, that table. When it comes to access, 82% of the studies we examined associated CON with diminished availability and access to healthcare services. Moving forward to quality, you'll see that 55% of the tests that we examined associated CON with diminished quality of services. And that looks at not just like the output of the surgery or the healthcare procedure, but also things such as acquired infections as well, and other associated bad healthcare outcomes during the healthcare procedure. And then the section 4 on page 28 for testing underserved populations, 80% of the tests we examined were associated CON laws with worse outcomes for underserved populations. And if you think about it, I think everyone in this room would acknowledge when we consider underserved populations, they're typically associated with a lower percentage or lower proportion of commercially insured patients. All healthcare providers subsist off commercially insured patients. And so if there already a lower proportion of profit margin to be had in these areas, it makes sense. Why don't we add a more expensive and a more timely process for any potential provider to locate in this area? And so that's what the research has shown us in terms of like allowing for CON to and why it's limited the ability of providers to open in or the want of some of these providers to open in these areas with underserved populations. I'd mentioned earlier, there's another handout you should have in there in front of you, and that is the millage rate handout that's created by the Georgia Department of Revenue. I provided that for the committee. I know in this year, the House Health and Human Services Committee, when they had testimony for SB 99, which is the rural hospital CON bill, There were some concerns expressed by the committee members regarding if there was a lessening or repeal of CON laws, what would the impact be for those counties that are currently on the hook financially for the existing facilities? That's a 44-page document. I have dialed it back here to the 10 known health facilities that are receiving funding. The one caveat with that is, in my research on authorities, I know that some counties use the development authority to fund their local hospital. I don't have a comprehensive list of that. So this is just the ones here that I know where they've explicitly stated they are funding the hospital. And you'll see here we have the one county, Habersham, that is currently using a bond to pay for that facility. But that document came straight from the Department of Revenue. And the other thing I wanted to address today is, I mentioned earlier some of our neighboring states. Of course, South Carolina this year moved to repeal CON for everything but long-term care facilities. North Carolina scaled back their certificate of need laws. They repealed CON effective immediately for psychiatric beds and rehab facilities. And they increased their monetary thresholds for long-term care facilities that are currently located on site at a healthcare facility. They also increased the monetary thresholds for replacing their equipment and for diagnostic centers. I will say that the unique thing about that, from what I can understand about North Carolina, whereas actually we allow that DCH to unilaterally raise those limits, it appears that North Carolina does that legislatively. So it's not a true like for like. Interestingly enough, in 2 years, they will remove ambulatory surgery centers from CON for any county over 125,000 people. That is 23 counties in the state of North Carolina. Those ASCs will have a 4% charity care commitment, similar to what we currently have in Georgia under our LNR process for a single specialty ambulatory surgery center. In 3 years, they'll remove MRI requirements from CON for those counties over 125,000 people. Now in Georgia, using the most recent census, we have 19 counties that would qualify over at the 125,000 person threshold. And just for context, the dividing line around 125 is, I believe that Clark County would actually be the last county above 125,000 people. Carroll County would be the first one below that threshold, to kind of give you an idea for what that would mean in the state if you did institute a population threshold. Tennessee has also favored the population threshold for imaging services. In 2021, they instituted that same requirement for imaging centers. They did a much more kind of narrowly tailored theirs to go after Knoxville, Memphis, Chattanooga, Nashville, and a suburban county that also had the population threshold. So our two neighbors to the north are fond of using the population marker as well. And, you know, that was just some additional things that have come up here during the process as we all discover this. You know, there's a lot of information there in front of you today. I know that as Chairman Parrish outlined earlier, you have a mandate to go forth and put, you know, recommendations to ensure Georgia stays. You know, we remain a state with good and equal access to health care. And so I hope that the report, my summary of it, has provided, you know, a little bit of insight into the current environment here in the state of Georgia. And with that, I'm happy to take any questions that the committee may have.
Good. Thank you, Chris. A lot of information there. Any members of the committee? Dr. Rice.
Thank you, Chris, for your presentation. Very good information. I just want to add a friendly amendment to your handout. This was a handout that was actually created through our work with Fulton County, and it was meant to be a representation of what the ideal state would look like if we were meeting patients where they needed to be cared for. It does not actually represent the services that were accessible through WellStar. That would have been an ideal state if it happened. But this is what we put together from listening to our focus groups, our community engagement, to say where are people mostly having need and what type of services could be created in multiple settings and in multiple modalities to actually utilize hospitals only when needed. So that that is not the place where people are receiving care that could be done in an ambulatory setting. So that's what this was meant to represent. So that footnote probably needs to be changed. Thank you.
Yes, thank you for that, Dr. Rice. I just use that as an example of, I think when we have this discussion, so many people that I speak with, at least their minds immediately go to a CON is for a hospital. And they don't recognize the extent of CON requirements for these services. And so when I was speaking with that room of folks that the ARC put together, they were really shocked that of those 14 services that are highlighted beginning in the continuum of care, that 11 of those would require a certificate of need in the state of Georgia.
I definitely think it gives the committee something to think about if we're gonna be thinking about access to care and meeting the patients where they are, right, in the community, because that will reflect in impact cost and also convenience and also the experience that the patient will have. And so I definitely think it can definitely give us to think about, something to think about as a representative of an ideal state.
Yes, ma'am. Thank you.
Thank you, Chris. Thank you for your presentation and y'all's work on this. And I did notice a lot of the studies, this is an observation and then a question. A lot of studies, because of the lack of information about what's the difference between a CON and a non-CON. Some non-CONs have a moratorium, we found out last time, which is even more aggressive than a certificate of need process. But there's some association factors that go on that seem to say, well, this state has CON and these things happen, or this state doesn't have CON and these bad things didn't happen, or, you know, so I appreciate the fact that y'all put footnotes at the end, because there's a lot of this that's more association. I mean, a hospital could have fewer closures like in Ohio, but it may be that they expanded the payment rate for OB and pediatrics, like we've tried to do sometimes in Georgia. Just a quick observation, and the population issue is kind of an interesting one, as you say, our two northern neighbors have used. One of the things I've noticed is most of us would like our family member, ourselves, to go to a center of excellence, whether it's for hip replacement or pediatrics, cardiac care, women's care, whatever. More and more people are more willing to travel a little bit to go to cancer care, for example. How do you deal with the fact that especially with a full-fledged hospital, it takes a certain amount of heft to have enough beds to do great cardiac care, great cancer care, great OB care, pediatric care. It's kind of interesting. There is whereas for urgent care, you could split it up, or even imaging in particular with very little risk, you can split it up into small, you know, one of each of the four main machines, ultrasound, CT, MRI. You can set those up a lot of places without sacrificing quality, but more and more in healthcare, we're realizing that you need a certain number for your team to do every year.
Yeah.
How do you see the population level as an advantage? Maybe that model of recognizing the population is what's needed?
Well, I think that's a multi-layered question, Dr. Newton. So obviously, for just a pure sustainability, there has to be a minimum number of patients that come through the door every year. And one thing, and my colleague, Dr. Mitchell, is much more versed in this than I am, but you know, it would stand to reckon that if CON was operating as in its best theoretical model, for example, you have a captive population, and this particular set of surgeons they're getting all of the reps. But that is not actually what the research, the majority of research has shown in terms of quality. You know, I think too, one thing that we're getting at when it comes to the safety net hospitals is, you know, is it economically possible for a multi-specialty surgery center to open in so many of our cities and towns across rural Georgia? And just economically, that's just not feasible for them. And so that when I often have this discussion, that is a much more, it often goes in a different direction. I know this committee, the other body that's examining CON in the Senate, like there's been some back and forth on what exactly the directed payment program is. We don't seem to have a consensus answer on that. So I don't want to dive too much into that, but I think you're right in that both, if you look at it a state by state comparison, as well as even comparing it regionally across Georgia and county to county, for example, it's tough to just have this one size fits all answer for a lot of the issues you're speaking about there.
Thank you.
And that's the reason why we provided a number of states. Because, I've spoken with folks that want to know what Texas did. Texas repealed CON in 1985. And I can talk to 10 different people and get 5 different answers on what happened in Texas. Same thing goes for Carolina. And so that's why I used Florida specifically for the ASC example, just because it's a neighboring state and it's the one that's done it in a recent enough timeline to where we can examine kind of what this healthcare, let's just say post-Affordable Care Act healthcare environment is. And that provides probably the best data set I could come up with as a pure anecdotal comparison.
Thank you, Mr. Chairman. I have a question around sort of implication of your underserved populations.
Mhm.
It seemed to me that you were saying, and correct me if I'm wrong, that by eliminating CON, the supply would go up. Potentially, the supply would go up for providers in those areas, therefore increasing the ability for people in underserved areas to access healthcare. Is that what you were saying?
When you're saying the limiting goes up, what do you
Yes.
mean by that?
So meaning that sort of in underserved areas, if you have the ability to put an ambulatory surgical center in some of these places, or whatever that demand is that somehow by eliminating CON, I wasn't sure if you were saying this or not, by eliminating CON, you would increase the supply of providers,
Yes, sir. So,
and that would, help out that population.
so I'll say this, if you're talking about an area that is, we'll just say 95% commercially insured, I think providers be willing to endure the time and the cost to undergo the CON application process. If you're talking about an area that has 15 to 20% Medicaid, 10 to 15% indigent underserved, let's just say 40% Medicare, that very quickly becomes a proposition to where if you're a provider and you're looking to locate in an area, you say to yourself, do I want to undergo the CON process, both in time and in money? If I know at the end of the day, my profit is, I'm already going to be teetering on the black or the right below in the red in terms of a profit margin to survive and remain open.
Yeah, it does. And so I have a secondary question because when I think about it from an economic standpoint, it is like, you sort of have, you enter into this place of factor immobility.
Mhm.
And so when you start thinking about factor immobility, changing the production doesn't necessarily increase the quality or the service. Right. So we could change literally how we produce healthcare for folk in these underserved areas. It doesn't necessarily mean they'll be able to access it. And so I guess where I'm struggling is, how does CON, whether we keep it or we don't keep it, how does it actually increase accessibility in underserved areas?
Well, I think it's just the barrier to entry. And so that's two things. That's one is the economic discussion we were just having. But on the other hand, too, if the state, for example, denies a CON, you're effectively creating a monopoly in certain regions around the state. I live in, I guess it'd be an exurb would be the technical term for it, but we only have one provider. And I went through an elective surgery recently. I had one provider to choose from in my area. And we have good jobs, good commercial insurance in that area, but still I was limited to one choice. And so I think at its base concept, that's where the access comes from in CON. We didn't get into things like, I know that Ms. Chubb with the Augusta Birth Center is going after me today. We'll probably talk about some of the implications of what's known as the competitor's veto. But I think at just the base level, we're creating a high barrier to entry for a lot of these healthcare providers that do want to enter in at their community and provide a service. And I think the point about immobility is a great one, because a lot of these philanthropically oriented providers, I often cite the example, I had a physician's office manager reach out to me about a year ago at this point. They were considering putting an MRI machine in their office. The hospital and they were going to do cash pay rate because they serve a mostly immigrant population and they wanted to have a cash pay MRI. But they knew the hospital down the road from them charged 7 times the cash pay rate. They just said, look, we know we can never get it. One, if we don't want to endure the CON process because we know that they have advantages we don't. They ultimately end up hiring a radiologist, nurse techs, and got around the CON process that way. But I think there are a lot of providers that, especially as healthcare technology advances, that it's worth considering like their barrier to entry. You know, one thing that's really come to mind as I was doing the research for this, I was unaware of, cardiologists are not eligible for a single specialty LNR. And Medicare since 2008 has approved having pacemakers and other rhythmic devices inserted in the outpatient setting. So I think it's just, you know, there's obviously the big concepts, the survival of hospitals and this kind of equity of having to see everyone that we often debate, but there are smaller providers in this process that I think we often forget about. And quite frankly, you know, they choose not to undergo the CON process because they understand it to be arduous, both from their own personal experience or what they hear from colleagues around the state.
Dr. Rice.
Chris, in this study, when you all looked at North Carolina with the ambulatory surgical centers, and you said they had a threshold of 4% charity care,
Yes, ma'am.
how was that established, and did it make a difference, or does it make a difference of what percentage of charity care they are required to meet to enhance access? I assume that's why they were doing it.
Yes, ma'am. And so that actually is not in the report. That was part of their 2023 legislative package. They came out after we had written this study. But yes, they had established in code, and much like we have in code here in Georgia, we have a similar charity care requirement. And so I would leave that to the hospitals and ambulatory surgery centers to debate the efficacy of that such requirement. But we do have a similar statute currently in Georgia.
Any other questions? Scott? Yeah.
Chris, thank you for being here. Just a question of clarification. Back to the Florida ASC information in your report. I want to make sure that I'm understanding what you're saying. I believe that we're talking from July 19 to 11/22. You're saying that there were 64 new ASCs in the state of Florida as a result of the elimination of CON. And am I right that those are reflected in the back of the report on pages 40 and 41?
Yes, sir. Those are the ASC developments announced, and that is in the appendix in the back, along with each of those studies that we cited for the summary of the research.
And just so I'm clear, the start date of the CONs that you're suggesting are in the date reported column by the ASCs.
Yes, sir. That's correct. And we chose the date after the CON. There were it's reflected in the chart there, the immediate number, but I mean, you'll see that I believe we actually did have some in the immediate aftermath of the CON repeal announcement.
Okay, thank you.
Yeah, Dr. Hawkins.
Yeah, I was looking at your quality section there on page 26, 27, 28. Yeah, I know it's hard to measure quality, especially when you look at ASCs. And realize, like my experience on April 24th, I was supposed to have a knee replacement. I was IV'd on a gurney. Surgeon already marked my knee up. I'm going in, and the anesthesiologist stops us in the hall and says, I won't do you without an arc line because of stenosis. I have aortic stenosis. My point is that if you pick the healthiest people and do them in ASCs, they have really good results. And if you pull the healthiest people out of the hospitals, their results start going downhill because they're treating sicker people. So I hope at the end or somewhere along the way, there's a concentration on that, because I think healthcare outcomes really depends on the information coming in with the results you get out. You know?
Yes, sir. And we tried to account for those variables as much as possible, but at the end of the day, you're absolutely right. You know, there's the quote that often goes around, and I'm, you know, sure Dr. Newton's heard this till he's blue in the face going back to medical school, but medicine is more of an art than a science. And so you're absolutely right. So we try to control for that as much as possible, but at the end of the day, we're just summarizing that research that's already out there.
Any other questions or comments from the committee? Chris, thank you very much.
Thank you, Chairman. Appreciate it.
Next, Jimmy Lewis.
Good morning. My name is Jimmy Lewis. I'm CEO of Hometown Health. Little background before we get started. I'm an industrial engineer from South Georgia, grew up in Cordele. Grew out on the suburbs of Cordele, if you can relate to the suburbs of Cordele, Pena Baptist Church and such. I'm extremely interested in healthcare from a family standpoint because my family grew up on the farm as well, and we did all of the things that you do there and have grown to be interested. I'm an industrial engineer from Auburn, War Eagle, so that we can know about that. My experience comes to you from both healthcare and from industry. I worked in 6 Fortune 500 companies doing anything that you can imagine, and I'm buying them, selling them, starting and stopping them. And so from that standpoint, I bring an awful lot of experience in many industries to the table. And then I got into healthcare after having sold my company and been in healthcare for some 20, 25 years, looking at rural hospitals. I only deal with rural hospitals, and I want to share the CON issue to you from a rural hospital that you may not have had a chance to consider. And we have learned this through the pandemic, so I'll be sharing some of the things with this. I'll go to the end of the story and tell you, in my opinion, why it's so important to make sure that CON is dealt with and dealt with properly, because absent being dealt with properly, we can put the rural healthcare business out of business, and then we got a real problem. It's important to note that to start with, we in the healthcare industry in the state of Georgia have seen as many as 15 rural hospitals close over the last 20 years. We oftentimes hear about 8, 9, 10, but the number actually goes back to about 15. And I think that there was one Chairman Parrish that probably closed back in your neck of the woods in Soperton way back in the day. This is extremely important because when we lose a hospital, we lose the economic generator, we lose access. And to the lady's point, maintaining access, the whole conversation about rural hospital and rural healthcare is about maintaining access. Hometown's mission is to do whatever it takes legally, morally, and ethically to keep a rural hospital open to go in order to provide access, ongoing access, and not periodic access. So if I can go carry me over to the first slide. We may get to the first slide. We'll go past all that. Okay, this is interesting. When it comes to the discussion of hospitals and closure, these are rural hospitals that I can identify that have closed since about the 90s. And this is kind of interesting. Turner County and Ashburn closed, Chattooga County closed, in Somerville, Treutlen County over in Soperton, Dula County, Hancock County, Telfair County, Calhoun County, Stewart County, Charlton over in Folkestone, Wheeler County down in Glenwood, Hart County, Gilmer, Lumpkin, Banks, and Randolph. The story that I will tell you stems from the fact that I sat in on most of those closures. And I can tell you that when you carry a hospital through to a closure, you carry the community through mental anguish beyond anything that you can imagine. This is though what happened. The thing that's interesting here is the population that's impacted by this is rural, all rural. And when these close, that community goes away. Anybody here been to Glenwood lately to see what the economic opportunity is in Glenwood? Not very good. When you go over to Gilmer and see what has happened up there, better, but it closed because of problems during that time. And then in Banks, it's closed. Randolph just closed last week. These are hospitals that have closed, and the net of the problem is very critical. And you'll say, well, what has all of this got to do with CON? Very specifically, the problem with CON stems from the fact that the uncertainty that is created by the perception that ambulatory surgery centers can be placed in any nearby facility. They can take the product or the service out of the community and carry it into the next larger. ASCs aren't so much about going and locating in Glenwood. Not a lot of that. But the hospital that's nearest to Glenwood can put an ambulatory surgery center. And because we're a highly mobile industry, we see people move by car to that closest ASC. We put ASCs into the communities where these are problematic, and then we got a real problem because another hospital will close. Kind of interesting. I'll bore you with a moment with an interesting quote. This is from Becker's, and you may have seen this, but this is from Becker's from about a month ago. More than 300 rural hospitals are at risk of closure in the United States. And of the 300 that there, 12 of those happen to be in the state of Georgia, 12 on top of what has gone on here. If we deal with the threat that comes with CON going away or whatever, because of what it does to access, then what we do is we destroy the access to the rural community that you alluded to. This is critically important. You say, well, that doesn't happen to us. Well, there's another aspect, interestingly, that creates a real problem. How many of you, well, you probably not. I would say, if you look at the state of Georgia, we've had another interesting CON issue to occur, and that is we have dropped out, or we have had the elimination of some 12 to 14 OB units in the state of Georgia. And the chairman and others can see that we've had those OB units to close and have not reopened. And I'll talk about a solution to that, but CON governs this in a very major way, and it's extremely important for us to deal with that. I show you this to say that this sets the stage for the fact that the CON discussion is a rural issue, and we need to deal with it. There are more hospitals to close, as pointed out in Becker's. 12 of them, they say, are vulnerable in the state of Georgia. We know that there are hospitals in the state of Georgia. We don't know that there's 12. There's probably 6 to 8. You say, well, name them. And the answer is we will not name them. And the reason we won't is because we had one hospital that announced that it would close one morning, and the vendors did a run on it before dark and took the equipment out of the hospital. So we can't name the hospitals, but we can tell you that we've got major problems with the hospitals. Let's go to the next one. Important to understand what the current situation is in the rural community, so you know what happens if we start to create problems with the certainty. Rural communities right now have a workforce shortage. We have a financial stress situation out of the COVID and the pandemic. 2 days to 10 days is not an unusual operating experience for a rural hospital. We've got, I said, financial stress. We've got a transition to AI, and I'll speak to that in a minute, artificial intelligence and what that will do to us. CON and M-Surge I'm talking about now. We got readiness, pandemic readiness, and it's kind of interesting when I travel around, and I do about 40 to 50,000 miles a year, not clinical, but operational. And what happens is we have a situation right now, we're creating a new pandemic, and it's called heat. And this heat pandemic is putting the stress on the ERs and all that goes with it. The big problem is, again, inflation. If we've got inflation, it's 12 to 15%, and our fixed contracts are giving us 3 to 5, then we're losing 12 to 14% on an ongoing basis. We got 10 initiatives that are going on, and these 10 initiatives, I won't name them all, but for example, CON, what happens for the CMOs, I'm sorry, with respect to the RFPs, what's happening with all of the other initiatives that we have. That's a resource consumer for rural, and when we threaten them with the loss of CON and the services that way, we would have a real problem. We got the economy is consuming the nature of our skill sets. The payer mix, you probably don't realize what happens in payer mix, but in a payer mix, we got a situation already in rural where the payer mix gives us 6 to 10% self-insured inability to pay. That's a real problem. 340B, you may or may not know what 340B is, but 340B is a pharmaceutical compensation program. It's under threat. And then an interesting thing is we got transport issues in rural Georgia, and the transport issues stem from the fact that hospitals are being forced to pay to transport a patient to get them to the hospital just for them to get services. I show you that to say that stress on the rural community is real. It's big time. And if anything else occurs to threaten the fragility of it, then we can lose many more hospitals. So you say, okay, to the chairman, Parrish. He asked, what are the solutions? I'm going to give you some solutions. And the answer to the solutions was anything can be on the table. So I'm giving you an offering of anything to be on the table. And so you can fall out of your chair or whatever the case may be, but this is what some of the solutions may be. Could you give me the next one? All right, if I can and may, the problem in rural community and in access is just cash. We can talk about a lot of things, but the truth of the matter is it's just cash. It's cash since 1999, when the governor at that point in time had a major fiscal problem, and he chose to fix the fiscal problem by cutting Medicaid to 85.6% of cost. And it stayed that way from then until just recently. Because it stayed that way, we are underfunded on every aspect of rural communities, the least of which is the depreciation of the systems. Virtually all rural systems are depreciated fully. And as a result, that's what caused the Cuthbert Hospital to close last year. So one of the ways to deal with this is to produce cash. One of the simple ways to produce cash is to adopt Medicaid expansion. I understand all of the politics associated with it, but the simple fact of the matter is, if this could pick up 500,000 people or so for coverage on a payer mix that is 6 to 10% underpaid right now, That is a major, major program to produce cash. And that's one simple way to do it. You say, why does that got to do with CON? Well, this is where we get money to continue to provide the services. And this allows us to do that. The next one is to increase the rural hospital tax credit from 75 million or whatever it is to 150 million. And I can tell you from all of the means of putting cash into the system, and it's about cash, all of the means of putting cash into the system, this is the simplest, the cleanest, the most effective use of cash that I've seen in all of what I'm doing. And the reason is that money gets brought into the community by the local hospital to be used by the local hospital. And it's not encumbered by commissions to be able to prevent the use of good monies to make that work. The next one is to replenish the State Office of Rural Health money and the stabilization grant. We had a stabilization grant that's about 5 years into it. And I think we're probably looking at or have had discussions to cut that. Those 5 years or so, if that money is cut, that was clean money to put into the hospitals. And usually there's 15 to 17 hospitals got the money. And we can point to the fact that had that not been there, we would have already had hospital closures. The next thing is to subsidize OB. We've got, as I said, 12 to 14 OB units have closed. And those closed because they were incurring in the vicinity of $1 million a year losses. Regardless of what the numbers were, the losses were $1 million a year. And at $1 million a year, the community said, we can't fund that. So they closed them. What you may not realize is that we have an OB desert in the state of Georgia below I-20. Most of these hospitals closed below I-20. And as a result, in addition to the other closures that you saw right there, these 14 exacerbated the whole access to healthcare. And we got situations now where the delivery has to occur somewhere between point A and point B, and the difference between those 2 points is 60 miles. That's a real threat. The CON is a proper problem with respect to OB, and it needs to be addressed from that standpoint. So these units have closed. It's a real simple deal. We could probably put, $1 million a year in 14. That's $14 million. Double it, get $28 million. $28 million will put those OB units back into business, and as a result, we could put those deliveries and that healthcare access back into business. The other thing that's interesting about this is the OB units are major drivers of economic development. When the OB unit closes the hospital closes, and the economic entity starts to go away. Another interesting one, we got major problems keeping docs in our communities. So the thought was, and these are conversations that have come up from the many CEOs that I've had a chance to go out and chat with over the years. Create a rural stipend for rural physicians so that there is a payment to them to keep them in the rural community. $50,000 a year, and you got whatever that is, 50 or 70 docs that you want to subsidize. That is ensuring the ongoing viability of the local access in the community, a major one to consider. The next one is we learned in the pandemic, telemedicine. Telemedicine is a key and critical source of service supply, and it worked. We know it does. We had a high use of it to go into the pandemic and COVID. Pandemic was over and we started to migrate back a little bit. We need to figure out how to incentivize this. And then the last one is always the one that always gets a lot of interest, and that's kind of what do you do with CON? We got a real problem, and we can talk all of the reasons why CON is such of interest today. One interesting thought that came out of one of our conversations, why don't we create a statutory exemption for one county in the state of Georgia to build one hospital? You figure. And then the next one is to leave all remaining CON guidelines for revenue for AmSurge and make that work. So I can talk forever and ever on these issues. As I said, I do about 40, 50,000 miles a year. I work in all of the rural hospitals and have for a long time. These are some innovative thoughts, and I'll push. Thank you for your time, Mr. Chairman.
Thank you, Jim. Representative Cooper has a question for you.
Okay, Jimmy, I think one of the things that's lacking from your presentation, and it's Dr. Newton sort of touched on it. People do want to go to centers of excellence, and people in rural areas have that choice also, to not be seen in a small county in perhaps a hospital that looks like you've shown, but to go to a more up-to-date hospital where they feel like, or to where they can have be treated in a surgical outpatient, surgery center. And I think that one of the things that we have to look at is the kind of care we give, and that the quality of care. You say back here, and it takes 40,000 patients a year to run a full fledged
Unsubsidized
hospital.
hospital, yeah.
Pardon, than the counties. And lots of the counties, I would like to see these ones that closed. And I'm taking the one of this in Vienna. My husband worked off his student medical loan in Vienna, and there's nothing there. And I would say there's not much enough surrounding it to really run a quality small hospital. So would it be better to maybe come up with a new kind of situation where there's emergency care, perhaps observation for a day or two before they just send them away, but to have that availability? But if they're, if we can't have up-to-date modern small hospitals in good facilities that have up-to-date materials and facilities and x-ray machines and all, isn't it better to try to find a new way to get people in these rural areas that don't have enough people surrounding them to support hospitals to get them that kind of care, rather than try to keep supporting a rural hospital that's old, doesn't offer some of the latest techniques and the latest services that are, more up to date and easier on the patients?
I think the answer to that would be it's easier to have a hospital that doesn't have the newest facilities in it and not die than it is to have a hospital that closes and everybody around it's subject to die. That's the first order of business, because in these rural communities that we have out in the marketplace, those people out there, for example, the poverty stricken, those people don't have a problem having their acute care taken care of and not having a heart surgeon in Glenwood, Georgia. That's the first part of that number one. The second thing is the federal government has initiated a new type hospital, a rural emergency hospital,
right.
Put it out into the marketplace. And I can tell you, it ain't working. Now, there are a couple out there that have converted to it. We've done pretty extensive research as to what it's all about. I suspect that there'll soon be a time where for those that are out there, there'll be a major clawback, and it probably won't work. We've done a lot of research on emergency rooms, and we found out on the stabilization grant program that the typical rural hospital emergency room, if left standalone, would lose at best $1.5 million a year. So the point of it is, everybody would like to have a heart surgeon, but the person that's dying out in the field that's got diabetes or whatever and needs treatment there, they're much happier than to die en route to a hospital.
Well, it seems like that. If you're going to, to keep a hospital open, you've got to have several different kinds of physicians. And if you're going to supplement them with $50,000, it seems like we would be better to supplement primary care physicians in these rural areas to help people not get to the point of dying with diabetes, and then have a way of getting them to a hospital that is more equipped and, and try this new emergency surgery. I don't know. It just seems like it's that underlying all of these, trying to keep them open, is the quality of care that a lot of people that live in these rural areas feel like they're missing if they go to that small hospital.
I'd suggest that the acute care that's being addressed in the local hospital with those patients, the quality of care that they get with the services they provide is extremely adequate and does a very good job, and the patient satisfaction is very high.
Okay.
Not a question.
Go ahead.
Yeah, thank you. And thank you for being here to do this presentation. I think you bring up a lot of good points. Chairman Cooper also brings up a lot of good points. We do want quality care in rural areas. However, in areas where hospitals already closed or approaching that point, I think people are looking for good emergency or preventative care. In the So Glenwood is in my district, and when I talk to the people of Wheeler County about this, they are they don't seem to be worried about whether they could get to a hospital to receive quality elective surgery. And by elective, I mean non-emergency surgery, so necessary but non-emergency. They seem to be most concerned that if they receive a severe injury or are in the middle of a heart attack, that they don't have anywhere to go anymore without driving to Dublin or Vidalia, and that's quite a drive. I know I heard from ambulance driver a few months ago that spoke about the fact that in some parts of my district, it takes an ambulance 45 minutes to get to a hospital. And that's after they've driven to the person, stabilized them enough to get them in the ambulance and then get them to the hospital. So I'm not disputing any of your points. I just feel like we've got to look at, practical solutions here for rural Georgia, because we're not going to go into some of these counties that have 8,000 people living there and have a state-of-the-art hospital that provides every service imaginable. So I'm hoping we can. I hear you. I'm just hoping we need to be very realistic about what we can do in these very low population counties.
Be assured.
That's all I'll say about that.
Be assured that access is critical to the rural community. And there's been many different searches for emergency care. And that's one of the feds are coming out currently with this REH. When you look at what it's about to do, that particular program, that hospital is forced to give up its acute care in order to deal with emergency care. And that puts a real problem on it. Now, another interesting thought about this whole situation is that with respect to the ASC, Ambulatory Surgery Center, we currently have situations where rural community docs are moving patients to an ASC 30 miles away or 40 miles away. And as a result of that, it's putting a threat on that hospital to provide local acute care in the community. That's a real challenge and a real problem in and of itself. We also have a situation where the insurers are taking patients that have been authorized to go to rural hospitals and sending them 40 miles away at the expense of the local patient. That's a problem. So for whatever we can do to keep healthcare in the local community, it's just critically important. Now, about the population, I did the calculation on the population, and everybody says, well, how do you get 40,000? It's pretty simple. In a local rural community, it takes two orthopedic surgeons typically. Orthopedic surgeons does about 17 to 20,000 in revenue a year. That's 35,000 plus the other acute care on top of it. So 40,000 population is based on the ability to support physicians. And that's kind of where we are with respect to that. The other option then is politically not a very good option. It's a real option and it's been tried, but it's not a good one. And that is those 15 hospitals that closed are for the most part from counties on average of about 15,000. The real smart thing to do is to do what Georgia didn't do a good job of in the beginning and go to consolidation of counties, period. It takes 40,000 population to do it, no matter how you shake it. And I've been in many conversations where, okay, let's just hire another surgeon. One surgeon does a really good job for a little while and then they get burnt out because that's in a rural community. That's a real challenge. So that has to be dealt with and has to be figured into the equation. But the 40,000 population says, if we're ever really going to address healthcare in the state of Georgia, we got to do consolidation in rural. And the probability of that happening is politically I've been run out of counties by making that statement.
Okay. I mean, that's what
I drove from Atlanta, Georgia, all the way to Fort Gaines and made a presentation to a board, and they asked me to leave and don't ever come back.
Lack of telling it like it is not your weakness. A couple of quick points. One, a little bit of good news. You mentioned Medicaid expansion. As of July 1st, Georgia did expand to the working poor in many of those rural communities that are the backbone of much of Georgia, that there is a new opportunity if they don't make the federal poverty level, they'll be eligible for state-funded Medicaid. The great news also for the people is if they're above 100% of the poverty level, up to 138, we're not making them come off their ACA plan, their Obamacare plan. We're letting them stay on it, which pays your rural hospitals commercial rates, not 85.6% of cost like Medicaid does. So we've got some good news for all those people that are hardworking across rural Georgia. But that's just
Excuse me,
one.
let me add something to that though.
Sure.
But as a part of that particular project, we're though in the middle of unwinding. So at the same time, we are getting people covered. We're unwinding at 100 miles an hour.
Well, unwinding is a federal requirement. If you want to be on a federal program, you've got to follow the federal rules, and unwinding is a mandate.
I
So we
understand
can't.
the realistic impact is right now we are unwinding, and we probably already unwound 50, 60,000 kids, and we're going on to several 100,000 in the state of Georgia that we will unwind. And that means we're taking them off the roads.
Well, hopefully a lot of those are going to be eligible for ACA plans, which once again will pay your hospitals and safety net hospitals even better. One question you mentioned, consolidating counties, which is I agree is a political non-starter. I know some counties that I work in that are 9,000, 19,000, 21,000, and they each have a hospital. It may be a 25-bed hospital that Chairman Cooper mentioned with an average census of 8 or 10, which people just bypass and drive over to Athens, or they drive over to Macon, or they drive somewhere else for a larger, more modern hospital. They drive to Brunswick. Has anybody looked at the counties and said, use this magic 40,000 number or 50,000, some number, without worrying about giving up the county seat in 159 counties, which is we're not going to be able to do, I don't believe. But we could look at the counties and say, listen, there's 3 of you here in these 4, or 3 hospitals in these 4 counties. That's 40,000 people. We need 1. We could sustain 1. Now you got to figure out which 2 do you ask to close? Do you close all 3 and get somebody to come in and build a bigger one? Kind of like your statutory exemption for 1 county and 1 hospital. Do you try to get somebody to come in and build a successful one that replaces, say, 3 25-bed, average census of 8, daily census? Has that been looked at?
Somewhat, and anecdotally, but not scientifically. And the reason I say all of those things as caveats, I can give you one situation where 3 closed and 1 came back, and that's down on Lake Oconee. Okay, that one.
That's unusual,
So that's an example. The other one though is if we can go over to Cuthbert and we start to look at the ability to consolidate and do things over there. No matter how bad it is, ain't nobody interested, and they'll tell you real quick, don't come back, don't propose it again. Period. That's just the way it works. Now, the interesting thing is in these conversations that we've had with the various counties, the subject would be, what does it take to keep your hospital going? Well, we got to have 40,000. Short of 40,000, what does it take? Well, it's a linear kind of situation. It's 40,000, 30,000. So what you really translate into is cash. And the way you translate into cash is it goes straight into what the county's willing to subsidize. And so what I learned a long time ago after having been run out of one county, literally in the city, I had it explained to me that you don't understand. We make our decisions about how we want to live and how we want to die. So the way this is going to work is we're going to put this to the people, and we're going to let the people decide whether they want a hospital or whether they want to pick up the garbage. Did it in a referendum for real? This is not politically correct, but they explained to me, you got the Ben Hills and the Come Hills. And the Ben Hills are those people that lived there from the beginning. And the Come Hills are the people that moved in, and they bring other issues that they want dealt with. And in this particular case, the county chose between picking up the garbage and closing the hospital. They closed the hospital, and a lady almost burned to death 1 month later, and she laid on a gurney for 2 hours burned before they could get her to Gainesville. That county chose not to fund themselves. Another county over in the central part of the state faced the same situation, and they chose to fund it. The subsidy is about $2 million to $3 million per year in order to carry one of these. But it's all a function of the people's will to live and their ability to finance it. So, and the other thing is, you have to, in rural communities, the people that drive the train are the people that are the landowners that pay the tax. We had a situation, and this is a public situation, down in your neck of the wood over in Telfair County. When Telfair came up, it had a problem. They had $2 million in the bank that was hospital money. They were running out of money. We had 10, or there about 10 community meetings to explain the need of money and how to get it. Had it all ready to roll, had a county commission meeting, called it on Monday night. Everybody showed up. And before it got started, a dude stood up in the back and says, Mr. Chairman, I have one point to make. And the chairman says, okay, what is it? He said, I'm going to vote no on behalf of the following 10 landowners, period. They shut the meeting down at that point in time, and the hospital closed on Thursday night from that statement on Monday. Every county's got a different will to live. And if you think you can go in and change their will to live, bless you, because that's rural Georgia's got its deal. I mean,
Okay, on this one thing, Jimmy, if we don't agree on anything else, we agree on this one about the hospitals not wanting to work together to, to consolidate. I think if you'll ask Chairman Powell, he will tell you that whatever they did to that one up Lake Hartwell, they were consolidated 3 counties. There's the 2 that didn't get it are still mad as wet hens.
Sat through that one complete. You can get yourself killed sitting in one of those meetings.
But I think the other thing too, we have to look at, and this came out of it with Chairman, the Appropriations Chairman Passwin, is that we really found a problem that a lot of the problems in these small hospitals are the people that run them. There was one county down somewhere close to the Florida line. The hospital administrator told us that people on the board were really nice people, but basically only one of them had ever been out of the state of Georgia. And we had to change the rules on making the requirements for what you can do to serve on a board of a hospital. And we had to make them mobile because they wouldn't go anywhere to get the education.
To that point, we did policymaker tours through the various communities, and Chairman England and others have been on those tours. On one of those tours, we heard exactly what you just said. And out of that, there came away the development of the board training.
Right.
We now have got the board training, very good board training, and every board member in the state of Georgia is trained on hospital finances and politics.
Well, yeah, because we put in there
Hey,
that if they don't get their Medicaid
that's
reimbursement.
exactly right.
Pretty big incentive.
and to that extent, we've had much better decision-making in hospitals. Not that it's by far the better, but from that point until now, we've got board training that is far beyond anything we've ever had.
But I mean, it's just a problem. And how far do we go in the state in supplementing when you've got that kind of an attitude? There needs to be some buy-in from the community. They're going to help and be responsible. But one more thing. One of the problems that we have with small hospitals, because I've been working on maternal mortality, and small hospitals that only deliver a few babies, and it's not a regular thing, like we have on 85 or 90% of our hospitals, we've trained a certain group of nurses to do, it's called a bundle, but it's not a bundle, what to do with hemorrhage, which is one of our biggest reasons for mothers dying. In the small hospitals, they will tell you that they don't have anybody that's regular or that you can train. So it puts them at a real disadvantage in delivering mothers. And there really shouldn't be delivering mothers in those small hospitals.
But the question is, do you deliver and live, or do you not deliver and die on the way to Augusta?
I think we have to find a way in between. Okay, sorry.
Well, I'm glad I'm not in politics anyway. I know and understand the economic drivers, and I'm just going to ask us to, we got to think about access and quality. And I feel that one of our opportunities is to bring the objective recommendations that definitely incorporate access and quality, such that when we go to our individual counties and present them with information, that they understand that we are putting the people first. And when I think about access, I'm thinking about preventive care, emergency care, and pathways to care that require hospital stay. What we recognize now, and we saw this during the pandemic, that was a lot of modernization of our care delivery that was needed. And we were forced into it using telehealth and other means. And we were able to care for people. And now what I would hope that we would do is think about what did we learn from that? And how do we put that in use such that we don't have counties that are having to decide between, trash collection versus keeping the hospital open, because we presented them with solutions of how care can be delivered in a way that meets the patients where they are. When we developed this, it was based on a study that we did, listening to the community, understanding what the most crucial healthcare needs based on chronic diseases, acute diseases, emergency care, maternal care access, and said, okay, how do you meet the patients where they are? How do you create services, whether with the CON or not with the CON? And that is to be debated, but meets them where they are based on the need, such that they have to travel less and have least inconvenience, and we can lower the cost. And I think as we make recommendations, we have to consider this, that people are living differently and have different desires. And it really is important that we are able to offer the highest quality of care combined with access and taking into consideration the costs. And so I just want to make sure that we stay focused on that, and that as we bring forth the recommendations, that we are not so much driven by the economics, but we are driven by what is going to be able to ensure that that person lives, whether they have a hospital in that community or a hospital 50 or 60 miles away, that we have provided in that interim space opportunities to address the needs that they have, such that they get to that hospital safety, and are only using that hospital though for things that are necessary for a hospital.
And to your point, Mr. Chairman, in your community, that subject is to the will to live by the community. Jenkins County made that will to live decision. You're very familiar with it. It was facing closure. It was at closure's door. The county saw the need, will to live to service this community, and they put a couple of $1 million back into it, brought it back, and that hospital is now providing access and doing a very good job. That's an illustration of what happens when the county makes that kind of decision.
Yes, sir. A quick question, I guess, because of your two things down here. Would you support, it was mentioned 125,000 or some number for larger urban areas that other states have relaxed CON or maybe eliminated it in certain areas where they don't have these challenges that our rural counties have of survival. They're more in a competitive mode with a lot of times plenty of cash in the bank as well. Would you support, would Hometown Health support some CON revisions as long as it left out rural counties, number one? Or would one other exemption would be, kind of relates to your one county, one hospital. If somebody's willing to come in and build a full service hospital, indigent care, emergency department, OB, everything into a rural area, maybe one of those 15 places that were closed, if we could eliminate CON or decrease it in populated areas, would the rural question be answered? If we kept the protection almost like a utility, and especially if we looked at that 40,000 number, would you support some changes in CON?
My only response to that is that's a function of every county's will to live and support it. I don't know that there is a global answer to your question as how we are where we are today.
I'm gonna go back to that 80 to 85% loss on Medicaid. You and I have discussed this over the years. I'm still struggling to understand how, if we do more of that, we survive. We're still losing 20%. I guess my question to you is Commissioner Nagel's work with CMS, is that helping you make up that loss, that 15 to 20% loss, or what does that future look like, especially for the rural hospital?
And I'm assuming you're referring to the direct payment program.
Mhm.
The answer is yes, it is most helpful. The further answer is it is not at all what it was thought to be going into the program. Now that we are in it, we're finding out that yes, it does help, and it does integrate with DISH and all of those other things. But from the beginning, there was the apparent understanding that this will make all rural hospitals whole.
Right.
It did not. It did not at all. So we're still struggling in part with that difference of whatever it is, commercial to 85.6%.
Okay, so again, back to my question, if we put everybody on Medicaid, you're losing 15 to 20%. How long do you stay open losing 15 to 20%?
As long as we got some kind of subsidy. And the reason I say that is because what has happened is when we get to Medicaid expansion, what we're doing is we're paying in a larger part that has not been paid for before. If we've got 20 years of 85.6% and we've got 6% that's not being paid for at all, and we get that paid for, we're minimizing our loss. And I know that sounds crazy, but basically what that does is that moves the opportunity to fund it back over to the county. And counties, they make some interesting, crazy decisions. Some, would say really good, but some would say, really? And interesting, when a county makes a bad decision, it takes about 3 to 5 years before they then further understand how much debt they incurred and they have to deal with it.
Good. Thank you, Representative Cameron.
Yep. Thank
And
you.
we're going to wrap this one up.
Okay. Thank you, Mr. Chairman. I just want to make a point with the northwest corner of Georgia where I'm at. We used to have a hospital, it wasn't on your list, but Hutchinson Medical Center.
I took it off.
Yeah, Hutchinson Medical, thank you. Hutchinson Medical Center was owned by the 3 counties. The county I live in, Walker, made a decision to subsidize after another group came in to manage that hospital. And the $10 million just almost helped Walker County under.
Yeah.
And it was, I don't know if all these hospitals are closing for the same reason. I understand what you're talking about in funding, but in that case, that hospital was horribly mismanaged and it went kaput.
One of the things that was learned out of all this process in my 25 years at it is the simple fact that managed hospitals, and this will get you killed because I did this, but managed hospitals don't work. And the reason they don't work is because the management company typically takes the cash that's being paid for the lease and doesn't pass through. And
Yeah.
I sat through all of what went on in yours, and that's
Yeah,
exactly what
I did too,
happened.
because we ended up changing the government
Yeah.
because of that from a 1 to 5. But one of the things I'm hearing from my colleagues too is innovation, whatever shape that takes, that's something that we need to look at too. How do we innovate healthcare? Thank you.
Well,
very much.
I'll speak to that and then I'll push to the chairman. Anybody familiar with the new term artificial intelligence? You need to know that artificial intelligence is in the process of making a transitional change, the likes of which we've never seen before. The problem in the rural community is the fact that the resources required to adopt artificial intelligence are beyond what's out there available. So we've got to figure out how to deal with it, but it's not a matter of choice of whether or not we're going to adopt artificial intelligence. It's here already in so many different forms. We just got to figure out how to adopt it in the community and in the facility.
Yeah, thank you for your presentation. A lot of information and a good discussion. Next, Liz Coyle.
Good morning, Chairman Parrish, Peter Beverly, members of the committee. I'm Liz Coyle. I'm the Executive Director of Georgia Watch. We're a statewide consumer advocacy organization, and we've been working on policy in this space almost from our founding 20 years ago. As everyone in this room became so concerned and has been concerned over many years, as the previous speaker, clearly 20 years of hospitals closing. And particularly in rural Georgia. Closer, thank you. Everybody hearing me okay? I usually speak so loud that I try not to hurt people's ears. But when recent hospital closures occurred in Cuthbert as well as the closings of the Atlanta Medical Centers by Wellstar in the most recent years, we began really Georgia Watch with our policy team, really digging into what are some solutions that are viable and politically possible to try to prevent several factors of the closings that were devastating, truly devastating on patients, employees of the hospitals, surrounding communities, and the neighboring health systems. And so you have in your packets, you should have a 4-page document in your packets that you received before the hearing. And then you've got some flyers that were just handed out just to add some color and some simple bullet points. I don't have slides, I've got the handouts, but I want to draw your attention to the 4-page document that was already in your packets. And we started looking at specific recommendations in Georgia code that we suggest could be modified to help increase oversight when hospitals are going to close, increase hospital and hospital authority accountability, and finally, increase indigent and care chair spending. So I'll start to walk you through that first document, that 4-page document. To put in real context, we were pleased to see earlier in the spring, the Department of Community Health looked at a proposed revisions to their requirements that will require 180-day written notice of changes to hospital services being offered by a hospital. We thought that was a great idea that DCH was considering. As of May 11th, to our knowledge, the board is yet to vote on this proposed amendment. And so currently hospitals like Wellstar only were required to provide 30 days notice. And that was one of the reasons that occurrence was so incredibly devastating and upsetting. So we believe that while we would support DCH adopting this amendment, we're asking the legislature to consider making it the law. I like to refer to this section of our policy recommendations as certificate of don't need. You all are really focused on certificate of need. I'm glad I wasn't here. Jimmy, he knows that inside and out. And y'all have to consider what you're going to do with certificate of need. I'm asking you to consider what we also can do to have a certificate of don't need. We did a survey, we commissioned a poll. We worked with the University of Georgia to do a poll in the spring. And that showed us, and that's on your first flyer, addressing hospital closures. According to the UGA poll that we commissioned in April, 82.9% of Georgians believe that the closure of a hospital should be subject to a 6-month review by the Georgia Attorney General and the Department of Community Health. You see, that's what's required for a certificate of need. They have to have at least, and we heard earlier, it can take, I think Chris talked about 500 some days in some circumstances. So if it takes at least 180 days to get a certificate of need, why shouldn't it take at least 180 days and that kind of robust review for a hospital to decide to close all or some of its services? So that's our first recommendation. I'll go into a little bit more detail there, again, going back to your 4-page handout. This would apply to rural hospitals, critical access hospitals, and safety net hospitals if they choose to close its doors, convert a freestanding emergency department, or eliminate service lines. Those decisions should be reviewed by the AG and DCH. And we also believe the State Office of Rural Health should be involved in reviewing that decision if the closure should occur in a rural county. And so we cite in the 4-pager the section of code that we think would need to be amended. And again, we want to urge 180-day advance written notice to DCH, the AG, the city mayor, the city council, and the public of the governing body's decision to close the hospital, eliminate a service line, or convert to a freestanding ED. We also want to have a lot more information about the finances involved in these decisions. We want a financial analysis to DCH and EAG demonstrating why it is not feasible to keep this hospital or service line open, taking into consideration the overall financial health of the hospital authority and healthcare system that may own, operate, or lease the facility. This analysis shall be made publicly available on the Office of Health Strategy and Coordination. It shall contain an overview of the hospital's patient population, including a zip code breakdown of patients by payer and identifying those patients receiving hospital financial assistance. We also would like to see some specific budget line items included in the financial analysis as well, and we can go into more detail. So these are just some highlights. And then we want this to be a much more public process than has occurred, whether it's in Cuthbert or in Atlanta. We want the AG or DCH to require community hearing. You know, there was a community hearing not too long ago in Augusta about Wellstar and AU merging. And we had an opportunity to submit written comments, other members of the public commented, and many were in favor of that happening. So we'd like there to be community hearings. When a hospital is closing or converting into a freestanding ED or eliminating a service line, there should be independent third-party health equity impact assessment to assess the potential impact on the community and medically underserved groups. Dr. Rice has talked a lot today about meeting people where they need to be met. And when some of you may have attended, participated in a hearing that the Senate HHS committee had prior to the start of these summer study committees that looked more closely at the impact of the closing of the two Atlanta medical centers on the surrounding health systems. And it was made very clear that with presentations from Fulton County, from Piedmont and Emory made presentations, Wellstar made a presentation, but there was clear evidence of a disparate impact on underserved populations when Wellstar made the decision to close those two facilities that were serving particularly lower income and communities of color in the city of Atlanta. So we want to make sure that those factors are more carefully considered in this 180-day review. We also want to make sure that there's a plan that determines how neighboring hospitals and providers will meet the emergency transportation and healthcare needs of the patients being served. Again, this was another significant part of the several-hour hearing that occurred in the Senate at the start of the summer. That really, you saw, you had testimony from the chief operating officer of the city of Atlanta, as well as the chief of the fire department and the police department, and again, for context here, we're talking about non-profit hospitals that aren't paying any local property taxes or their federal taxes or their state taxes. And then you hear from officials who tell you what the impact is on city services when a nonprofit that's not paying property taxes is taking all their marbles away and leaving this huge gap to be filled by the surrounding providers. So that's what we're seeking to address here with these recommendations. Fourth, in this section, we want to make sure that there's adequate time for community leaders or hospital governing bodies to secure additional funding from federal, state, county, or other sources in order to keep the hospital or service line open or convert the hospital to a freestanding ED. Now, Jimmy talked about $2 or $3 million that some counties made the choice of life over death. So, you know, maybe there would have been an opportunity had there been more notice for the county and the city and the region to come up with dollars to keep Atlanta Medical Center open. But again, lack of transparency and lack of time, what Jimmy is suggesting didn't happen. And it happened so fast, and the community is still devastated. So one of the things we suggest there is another potential source of the cash that Jimmy was talking about is looking into whether DCH could be allowed to allocate some of the Indigent Care Trust Fund dollars towards keeping a rural hospital or a critical access hospital or a safety net hospital open to continue service. So that's another thing we want to suggest. So that completes that first section. The second section of our proposal, if you look at, especially, unfortunately, the my paper slides are out of order. If you look at this, the increased hospital accountability in Georgia, the third flyer that you had in that little packet I gave you. The issue here is that hospitals and hospital authorities in Georgia are really only required to provide very limited public insight into the financial health of their health system. And that lack of transparency may very well be contributing to the problem of closures in the state. 12 hospitals have closed in Georgia since 2013. And I think looking back, you had 20 on your list in the last 20 years. So often with very little advance notice. So looking again to this section of the 4-pager where we're proposing increased hospital and hospital authority accountability, we want to make sure the public has meaningful access to information regarding the activities of local hospital authorities. And we propose revising the section of code to provide for withholding of state grants or funds from a hospital authority that fails to comply with certain reporting requirements, including preparing and filing an annual report, an annual budget, and a community benefit report. We also want to suggest that you require any corporation that operates, leases, or otherwise contracts with a hospital authority to be subject to the community benefit report requirement, and that Medicaid and Medicare losses not be considered community benefit for the purpose of the report, nor private insurance for the purposes of community benefit, unless those insured patients were approved under the hospital's financial assistance policy to have their hospital bills reduced. And I'm going to talk more about hospital financial assistance in the next section. Third, we'd like you all to consider requiring a hospital authority to file annual reports, budgets, audits, and community benefit reports with the Office of Health Strategy and Coordination, and require that such documents be made available on OHSC's website. We provide, and we also would like to you to provide that any subsidiaries or foundations established by nonprofit organizations that lease assets from hospital authorities be subject to state open records laws. A few years ago, there was actually a case, I believe it was Northside, and some of the some newspapers, it was a merger matter, and some newspapers asked to see some financial documents. And Northside said, oh no, we're not subject to the state's open records laws. That went all the way to Supreme Court. We filed an amicus brief in that case, and the Supreme Court did determine that Northside, as a nonprofit hospital, was subject to open records requests. But in fact, we believe it should be, that needs to be codified. We wanted to make it very clear that that's the case. And then some additional recommendations that we have to improve hospital authority governance. Right now it seems in Georgia that there's different hospital authorities play by different rules, it seems, because maybe the rules aren't clear enough. You've got the Fulton DeKalb Hospital Authority that governs Grady with an independent board, with robust financial oversight, with a real commitment from the counties to provide that additional funding to keep Grady Hospital open. But we have other hospital authorities. Wellstar has a hospital authority. Northside has a hospital authority. Those aren't the counties. Those are hospital authorities for those hospitals. Phoebe Putney's hospital authority is Sharon Cooper's making me laugh. Sorry, is Phoebe Putney's Albany Doherty County is the hospital authority for Phoebe. Do they have an independent board? Or are we looking in some cases at hospital authorities that are really a shell that's a pass-through for state and federal funds to a nonprofit hospital? So we'd like to see greater accountability in hospital authority governance. We'd like hospital authority boards, make sure they're fully informed, representative of the communities they serve, and protected from potential conflicts of interest. So we propose several things. One, we suggest that the code be amended to state that the hospital chief executive officer and/or chief financial officer report to the hospital authority board at least quarterly regarding the financial health of the hospital. And again, those should be public hearings, and that would provide greater insight. When we again look at what happened with Wellstar and what we heard in the presentation to the Senate about the state of the finances, why didn't the hospital authority board know about that, and why weren't there public hearings about the financial health of that health system? We also suggest revising to state that no current employee of a hospital operated by a hospital authority or a nonprofit organization that leases assets from that authority may serve as a member of the board. We think that's a conflict of interest. We think the board should be independent of the hospital leadership and not have hospital leadership on the board of the authority. We want the hospital leadership, the CEO and CFO, to report to that authority, to that hospital authority board. We also suggest that hospital authorities should contain at least one lower income community resident with a household income at or below 200% of the federal poverty level. We think it's very important for this, the makeup of our hospital authority boards to reflect the communities that they're serving. And that these would apply to hospital authorities created by 2 or more counties as well, or 2 or more municipalities, or any combination thereof. And so that concludes that section of our policy recommendations. And finally, I'll turn your attention to the last page and a half of the 4-page handout, and that is accompanied by the flyer that looks like this: increasing hospital financial assistance programs. And again, looking to our poll that we conducted with University of Georgia, 79.2% of Georgians believe that hospitals should be required to increase their financial assistance spending to help low and middle income patients avoid medical debt. So looking at, we also, the evidence shows that medical debt is crushing for many Georgians. We are currently some 100,000 Georgians have medical debt, many of that medical debt in collections. Even with the change in some of the reporting requirements, it's affecting people's credit scores. So we're looking for multiple ways of solving the medical debt crisis. But in this space, we're suggesting one thing we can do is to increase spending on financial assistance for patients who qualify. So I'll go into more detail there. But before I dig too deeply into this section of our recommendations, I want to refer again back to that hearing in the Senate at the start of the summer. During that hearing, Wellstar CEO and CFO were invited to address the committee. One thing in that testimony really struck me, and I think it was Senator Hodges who was asking questions that got this evidence into the record. So again, these are nonprofit hospitals paying no taxes, right? So there's that benefit that they have. And what are they supposed to do? They're supposed to be, for that benefit, investing in the communities where they serve. So in response to a question from Senator Hodges, the Wellstar CFO acknowledged that one of the reasons they, in private, decided to close AMC was for $16 million annual losses. Previously, he had been talking about the fact that a nonprofit health system set aside some 5% of the revenues for a reserve. So Senator Hodges said, well, so 16 million losses. Could you tell us what that figure is that you had in revenue that year for your reserve? 200 million. 200 million that they could hold on to, leaving a community devastated for 16 million in losses. So I ask myself, is that really the intention of the definition of a nonprofit hospital not paying any property taxes, and no local taxes to the city of Atlanta or the county or the state, that's still reeling from that action? So back to my the 4-pager and some specific recommendations to how we think this should be addressed so that that sort of thing doesn't happen again in Georgia. So again, most hospitals are nonprofit. They are exempt from paying federal and state income taxes, sales tax, property taxes, but currently there's no monetary requirement in current Georgia statute for an amount of community benefit or indigent and charity care spending. Currently, in the current CON law, there is only a specific requirement that if you are if you have a certificate of need and you're a destination cancer hospital, you have to commit 3% of your gross revenue to charitable spending. But the code does give DCH the authority to apply that in other cases of certificate of need. And as our research has shown that virtually all hospitals in Georgia who have a certificate of need, DCH does require them to set aside to provide 3% in charitable care spending. Jimmy mentioned actually it was Chris, I think, mentioned that in North Carolina, in 2023, they passed a law that made that 4%. Okay, so that's just for context. North Carolina, our neighboring state, in 2023 passed a law that increased or made in the law a requirement that nonprofit hospitals for AS. Oh, thank you, Chris. All right, well, okay, good to know. So our recommendation here in Georgia is that the DCH shall require a holder of certificate of need to provide uncompensated indigent or charity care in an amount that meets or exceeds 5% of its adjusted gross revenue. And that there'll be various monetary penalties if the hospital does not comply. Our research shows that there is quite a bit of hospital noncompliance with some rules because the fines are so small and, it's easy enough for them to do that. And again, I've just said that at least one health system, we're talking 200 million that they have in excess revenue at the end of the year that's not being reinvested back into the community as far as we can tell. So we think that's a reasonable request that's going to, again, help to address the high rates of medical debt. And these are people who are not just uninsured, but we have many who are and lower income. And we have many middle income Georgians who have a procedure that still, they might lose their house over it. So we're trying to find a reasonable ground where we're helping people get access to the care that they need, have a healthy health system, but in particular for those who qualify for financial assistance, we want it to be available to them and as robust as possible. So the next section of our page is a long list of the kinds of penalties for noncompliance. I won't go over those. You can see them in your handout. But we think that we need some serious teeth in this section of the code. And then any above monetary penalty recovered, we suggest that could be paid into the Indigent Care Trust Fund that then the DCH could use to potentially keep some of these hospitals open. And then finally, just a couple of things. We suggest adding a definition for uncompensated charity care and how it should be defined. And so you can read that section for yourself, but we think it's really important that what we have found, and we have a toll-free consumer hotline at Georgia Watch. So we hear from people directly who've been impacted, and we'll hear from someone who has a medical bill they don't understand, and they couldn't possibly afford to pay their medical bill. And then we find out a little bit more about their financial situation, and we say, well, did the hospital offer you financial assistance? Because it seems like you should have qualified for a financial assistance policy. And the hospital hadn't. So then, we can help them, but that's not right. If someone comes into a hospital, the hospital, when you're checking them in, how hard could it be? What's your insurance? What's your income? We think you might qualify for financial assistance. Let's make it easy, because medical debt is almost as crippling as what happened when Wellstar closed Atlanta Medical Center. And that concludes my formal presentation. So long as you're easier on me than you were on Jimmy, I'm happy to take your questions.
I got a couple of questions. Dr. Newton.
Thank you. And thank you for your 4 points. I have a question on two of them. One kind of relates back on when you're talking about let's give 6 months notice instead of 1 month. Jimmy Lewis mentioned it regarding a rural hospital, but it could apply to anyone. You start getting vendors repossessing their equipment. They cut off your credit line, so you got to pay in advance for gauze and anything else you need. You start getting personnel that start to leave because people aren't going to wait until the very end. Is it really realistic? And plus the fact, I know of a hospital in Pennsylvania, one of my kids was working in, that closed, that supposedly was losing $5 million a month. And Pennsylvania wanted to require him to stay open for 12 months. And I remember thinking myself, who pays the $60 million? If a hospital, and even on a smaller amount, $1 million a year, I think he said a rural hospital might lose on an OB unit. Who tells them I mean, who pays that $500,000 that they're going to lose in the next? How is it realistically possible if what he said was pretty accurate?
Well,
Notice of closure.
I think that that's why we have this robust framework that includes requiring every hospital, health system, nonprofit hospital in Georgia, governed by a hospital authority board, to make regular presentations about the state of the health system and have that information be publicly available. And the goal of the 180 days is to find time in that 180 days and resources to keep that health system open. We don't want it. I mean, I agree. We don't want this to be an opportunity to hasten the demise. Our proposals are all about trying to keep all across the state of Georgia, in urban and rural places, keep our providers where they're desperately needed.
I do. I like that. And also your hospital authority governance would probably quietly, they should know of it long before the 6-month clock started as well, if it was working the way you're describing. Final thing on the indigent and charity care. When somebody provides uncompensated indigent care, say an emergency appendectomy, I've seen the list prices for that for some friends of mine who've had it. The list price might be $40,000 for that 2 or 3 day stay in the hospital and emergency surgery and everything associated. You know, the contractual amount with, you know, any one of the major carriers is maybe 10 or 15,000. Sometimes it gets lower than that. Do you know, number one, do you know what number is reported if I'm the hospital reporting my indigent care? Do I report 40,000? Do I report what Blue Cross would have paid me? Do I report what Medicare or Medicaid? I know a couple of years ago we had a bill that Representative Hatchett and I worked on about, let's just make it 150% of Medicare, since most hospitals say Medicare is a rate that just barely covers our costs, or it covers our costs. Let's just let them report as their indigent care that appendectomy should be 150% of what Medicare would have paid for it. And then we get, rather than just charges that are all over the place, which we all know, someone mentioned 7 times Medicare earlier, which is not unusual. Would that be a way to actually make sure that this is real care and not just an artificially inflated list price that nobody pays?
Right. Representative Hatchett, Representative Newton, I appreciated the legislation you and Chairman Hatchett worked on together. And I think that was one potential solution. I actually had really smart young people in my office research this a little bit, because we've had this question before, and it does need to have a very specific formula like you've just suggested, because that is happening. We understand, I think it's called the charge rate or the charge master rate. What we it should be a blend of the billed charges. You know what? I'm not going to, let me just say, that's a good question. We have some more detailed answers that I can provide to this committee later in writing, but we agree it should be something that is not based on an inflated rate, but should be on something that's actually paid.
Well, thank you. I know we worked on garnishment of wages too, which is another thing with medical debt that is very difficult with, especially with a tax favored entity, but thank you.
Thank you, Representative Newton. And on that point, I will say in our same poll that I've talked about a couple of times that we did with UGA, we asked if Georgians felt that medical debt in particular should be subject to garnishment. And overwhelmingly, Georgians say, no, medical debt should not be subject to garnishment.
I was going on the same thing as that Representative Newton did. And having just had a 2-hour meeting with the head of Wellstar, I gave her an example of somebody who was in the emergency room. It was so overcrowded that she had to sit out in her car. Her foot wasn't broken. They put a boot on it, and there was a CT scan. The original bill was $30-something thousand. They reduced it to $9,000. But for this person, this will put them into that, area being a problem. So I agree that this is a problem. But the other thing on the rural hospitals, just what you are suggesting, and I'm not saying that in a perfect world, it wouldn't be right. The cost of accountants and people to do this is beyond most of these little rural hospitals. Am I right, Jimmy? I mean, totally. you know, if they were on the brink anyway, the kind of cost would just put them over the brink. Or the fact that they don't have the staff that's capable of doing it. Wellstar, you know, the ones up in Atlanta, the big systems that have the little hospitals, yeah, they've got the staffs. But the ones that are not owned by one of the big Northsides or Wellstar, Sanford, I mean, because I've worked with them as we talked about increasing the requirements for the board members and so forth. They don't have that expertise. And I can say in a perfect world, I can see value, but unrealistically, I don't know how to make that work.
So Representative Cooper, I just want to make sure I understand. You're concerned that in really small, these 25-bed rural hospitals, asking them to do the kinds of reporting that we're suggesting here would be an onerous burden. So maybe we need to think through a system whereby there are, you know, state accountants who provide those services to these really small rural facilities.
And the other thing, I really truly believe if you put it out in little rural communities that far ahead, I think that what Dr. Newton talked about is they would start to pull out, the doctors would start to look for other places to work. You know, they would, you know, transfer doctors. I really think it would be a self-fulfilling prophecy that they would then close. And the other factor is if it comes up that they're bleeding $5 million a year and you don't want them to close, where did they get the $5 million?
And I would suggest that Jimmy Lewis had a few of those suggestions, but I mean, I definitely hear you. And I think, you know, what we're hoping that you'll look at today is a range of possible solutions. We all have the same objective, which is to keep our hospitals open. Thank you.
Yeah, thank you for your presentation. You were talking about medical debt. Say you and I go both to the same hospital, we have a knee surgery, and I have Blue Cross, and you don't,
Right.
you're going to pay out of your pocket.
Right.
You know, Blue Cross may pay DRG or a fee of $7,500, but they expect you to pay the $30,000, or they may reduce it a little bit. Do you see people that get caught in this situation?
We do. And, you know, we back actually, and I'm very proud of this, back in 2017, we published the Georgia Guide to Medical Billing and Debt. We've had one person had an ischemic attack and went to an emergency room in Atlanta, had a $30,000 medical bill, had no health insurance, was underemployed. For a year, that debt weighed over her. I happened to be speaking somewhere and gave her a copy of this guide that we had just published. She took it home, followed the advice, and got that medical debt reduced to zero. Why? One was because she qualified absolutely for financial assistance. But again, this is an issue that you bring up that's really about price transparency and value. And we tell patients to be their own best advocates, and you have a right to negotiate your bill just like Blue Cross. But we're so pleased that the state of Georgia got ahead of the federal government and in 2020 passed, and of course, Chairman Hawkins was involved in that, and with Senator Hufstetler passed the Georgia Surprise Billing Consumer Protection Act. They included in that a provision to create an all-payer claims database to bring that kind of price transparency. So you know what the average cost of a knee surgery should be. And if this place wants to charge you 20 and you say, well, but the average is 9, maybe you go someplace else. So that APCD is in the process of being rolled out. And come January, people in the state of Georgia should be able to look into and get that kind of price transparency about what a procedure should cost wherever they go to get it in the state of Georgia.
Thank you, Mr. Chairman. I just have a quick question. What percentage of medical debt is caused by insurance denial of services? Do you know?
I can't tell you the exact percentage, but I can tell you that is a great question. And so a robust part of our guide to medical billing and debt, and we do workshops on it, and we train a lot of, you know, healthcare social workers and healthcare providers. People, if there's a denial, there should be a process that they can go through. It's supposed to start with an internal process. We had an example, this one made it onto the news, of this gentleman who needed a literally life-saving device. I can't remember the type of the device, and inserted for his heart to work. And the insurer was, I believe, Aetna, denied, did an internal review. And he had his local provider said he ultimately went to Emory to have it done. It cost him $120,000. But he'd been this robust person and fit, and he put on all this weight. He couldn't even walk to his mailbox until he had the procedure done. And now he's back to walking 7 miles a day. But what he didn't know at the time, fortunately, he had the ability to raise that money, right? Most people don't. He could have appealed that and should have appealed that to the insurance commissioner. And that's an independent process. And that's when that patient can get fairness for a denial, so that they are not saddled with $120,000 in medical debt for something that literally saved that man's life. Thank you for that question.
Yeah, just briefly, Liz, thank you for being here. Hey, just within the state of Georgia, are you aware of what the total amount of indigent care or charity care is provided by nonprofits?
I think that number is in my cheat sheet, if you give me a second.
Sure.
And if not, I'm happy to provide that to you, that information after the fact. Let's see.
And that's okay.
Okay.
If if you can supplement that, that would be great.
happy to do that.
Secondly, are you familiar with 501R requirements of the IRS with regards to charitable care responsibilities of nonprofits to report?
I do have that document handy.
It's a requirement by the IRS that all nonprofits have to report their charitable care policies, self-pay payment policies. It's already in
It's
federal law.
It's in the law. And what we found is that some hospitals are very forthcoming. You know, some people, it's on some hospitals is on the website, but you'd have to be a computer scientist to know how to find the information. Some hospitals post that information when you go in and you into the hospital in the waiting room, and when you go in to talk to the finance people at the hospital, that information is readily available. You know, we find that the IRC, the code, that section of code governing nonprofit hospitals, has many useful requirements. But just as we've asked the state of Georgia to consider quantifying, if this is your benefit from not paying taxes, et cetera, how do you quantify that equally in what you're investing in your local community? We think actually it would be excellent for the federal government to include that in the IRC code.
All are mandated. There's guidance around charity care and self-pay policy that has to be provided, reported, and supported in documentation. So there's an adherence, and there's federal law around that requires us to adhere to. Yeah, Representative Cooper, it's a little more complex than that.
It varies. It is not clear. It is not when you read the reports. I mean, we can do a much better job in seeing what the denominator is, whether we're using your base rate or whether we're using 150% of Medicare. And I think that's where the consistency needs to come in. So it's not clear when you read the reports. They are very complicated, and there's not standardization, even though it is required by code. It is not standardization of how the reports roll out. So you cannot really see what that amount is.
Thank you, Dr. Rice.
Thank you very much for your presentation. Certainly a good discussion, and I know that we'll be hearing some more from you and get this information that Ms. Raines had an interest in that number. Thank you very much.
Thank you.
Next on our agenda, Katie Chubb.
Good morning, Chairman, representatives, doctors, nurses, and supporters of the Augusta Birth Center who could be here today. Thank you for coming. So my name is Katie Chubb. I'm the owner and founder of the Augusta Birth Center. We're women-owned, locally owned, family-owned, veteran-owned, and minority-owned. I moved to America with $100 in 2009 in the pursuit of the American dream. I wanted to open the best birth center I possibly could. I wanted to open a birth center that not only provided mental health, physical health, nutrition, breastfeeding, counseling. I wanted to find a center that could revolutionize maternity care in the world, but let's just start with Georgia. We filed for a certificate of need back in 2021. I've done the whole process. 826 pages I wrote and filed and fought. Sadly, we were denied. We were unable to open and serve these mothers, not due to not meeting a need. Certificate of need said that we met the need. And actually, we went above and beyond meeting the need. And did you know that Augusta, we're ranked worst in maternal mortality? We're worse than Syria and Cuba. Syria is currently at war. This is a third world country here for maternity care. If you're a Black female, you're 3 times more likely to die. And that's unacceptable to me. I was inspired to move forward with my mission to build the Augusta Birth Center following my labor at the Atlanta Birth Center. The care I received there was like nothing else I'd ever experienced in the American care system. They cared. They taught me consent over coercion. I was educated on my choices. At 20 weeks, I had a 2-hour meeting with people in my due date group of how I wanted to give birth. Did I want to breastfeed? Was that not an option for me? What did I want to do? Did I need a doula? What were my options? And that was incredibly empowering to me to sit across from a midwife who taught me these options. It was a lot of focus on comfort, and there were emergency options in places. The center was well equipped. It was beautiful. And to this day, they have 0 maternal mortality, 0 fetal mortality after. Since I began my journey into opening the birth center, I've received endless support, and quite a few of them are here today on a Tuesday. They've got babysitters. They've had husbands and spouses care for their kids so they can come here and support us for this journey. There's not been a single person who has said to me, we don't need this in Augusta. In fact, my board is solely doctors and lawyers. My supporters here are a lot of nurses, a lot of midwives, some doctors. On top of that, just women in the community. Every day I receive 3 inquiries on my social media account from women who need services. But guess what? We're not open. I can't do anything. I can't send them anywhere. So up to today, I've had about 1,200 inquiries for services, despite saying on my page multiple times, we are closed, we are closed, we are not open. So our website makes this very clear. People will still reach out. Where can I go for breastfeeding support? Where can I go for this? Where can I go for that? I have to give unsatisfactory answers. I just refer them to a couple people in the community who know better than I do. I get questions at church on a regular basis saying, what can I do to help pregnant women in this community? I own a couple of small businesses. None of my businesses have ever failed. I'm a very successful businesswoman. I wrote the con. I wrote 826 pages along with my co-director, along with my husband. We stayed up 24 hours to submit the certificate of need. Because if you've ever tried to combine 400 PDFs into one PDF, that takes 24 hours and an IT expert. And we did, in fact, stay up all night, and we got it in by 11:50 for the deadline at 12 p.m. that day. So the solution I ask of this committee and for legislator as a whole is straightforward. Remove the certificate of need requirement. I'm sure you're aware, Connecticut removed it this week for obstetrics and birth centers. Birth centers, the American College of Obstetrics and Gynecologists, April 20th, 2020, made a statement. The safest place for birth is accredited birth centers and hospitals. There is no if or but, it is and birth centers. Data has long demonstrated that hospitals and accredited birth centers are the safest place to give birth in the United States. American College of Gynecology, 2019. Thank you for giving me this opportunity to speak. And I welcome any questions. You can be as fiery as you want. You can come for me. That's totally fine, because nothing is going to compare to the heat I was put under preparing 826 pages. I'm here to represent the future of women in this area, and I'm not going to back down. So give me everything you've got.
Sure.
Ask me questions about certificate of need too, because I think I'm one of the only people in this room that's hand prepared a application.
Chairman Cooper has a question.
Right. This is the first time this has come up about the birthing centers. Why were you denied a CON?
Okay, are you ready for this? The room knows what happened. We had to enter into a transfer agreement as one of the regulations. It is written as
To the hospital.
to the hospital. The hospitals found a loophole in this regulation, which is as it is written, not as it is intended. So I came up with a better solution. Let me partner with the maternal fetal medicine doctor in Augusta, who has transfer agreements to all 3 hospitals. Now, this gives my patients choice. It gives them options. But the con didn't want to hear it, because all they want is Augusta Birth Center to a hospital. Now, why would those hospitals not enter into a transfer agreement with me? Well, funny enough, this was about the time the purchase of Wellstar and Piedmont was going through. A couple of bonuses might have been on the line. I was denied, not because it couldn't be done safely. And I'm somebody who had a transfer agreement safely to Atlanta Medical Center from Augusta Birth Center. I know that we need these transfer agreements. But hang on, isn't there a regulation called EMTALA? And we brought that up to the Certificate of Need Review Committee, and we provided a rule variance request, which was denied. So it was the rule as written, not as intended.
Okay. Did the department do the denial, or was it because they had out? Was there also, besides the denying the hospital's not letting you have the transfer, were they also objecting to the birthing center in itself?
They did, and their objections were met with, that's not correct by
Right.
the certificate of need. They threw out their objections. Their objections were that they were already serving this community. I would like to say my second pregnancy, my first visit was at 15 weeks. I don't think that's serving my community.
Okay.
At a local hospital. They denied it based on the fact we were unable to obtain a direct transfer agreement from the Augusta Birth Center to the hospital, despite building in the Laney Walker area, and I can push a gurney out the back door of where I was going to build into a local hospital. It was competition, and this is monopolization.
Thank you.
Thank you.
Any other questions or comments?
Thank
Scott?
Katie, thank you for being here today. Just a thought around birthing centers and in rural areas, as opposed to maybe a more urban area
Yeah.
like Augusta and or other cities. What are your thoughts around that happening and the ability for that to occur?
That needs to happen. Let's look at North Carolina. Let's look at a couple of other northern states. Let's look at the Boston surrounding area where they go into some of the outskirts of the communities. That needs to happen. We had a bus that my husband is currently very proud of that we were going to take into these rural communities and serve there, on top of potentially branching out to building birth centers there. We can serve these rural communities. There's not a single death recorded. We have $2 million worth of equipment at our disposal. I have OBs on board, maternal fetal medicine. These are incredibly safe places to give birth because we have a risk criteria that you can risk out of. We can build these in rural communities, and I want to do that. I'm the person who can drive that forward here in Georgia, but we can't because it's impossible to get through the certificate of need process.
And just if I may, quick follow-up. So in just thinking that through with regards to rural communities that may or may not have hospitals within them, and if those hospitals don't provide OB care or any other prenatal or post care, what are your thoughts around the coordination of care and the ability to sustain that over time?
I think the coordination of care is very sustainable. There's birth centers in Arizona and Colorado that are currently doing this, and it's working very well. We have all the equipment to handle emergencies there. We can transfer. I mean, we have a great helicopter program here. There's a lot of options that we can do as far as transferring and working with local hospitals.
Well, you've stirred up several questions. James Cooper has a question for you.
Right. Are these centers staffed with the OBs and MDs and all, but also are they nurse midwives, people that
Yes.
have already done nursing school and have
Yes.
gone on to a graduate degree?
Correct.
Right.
We will not work with licensed professional midwives at the Augusta Birth Center.
Well, okay, and that's great. And we do have a new midwifery program at Milledgeville, the Milledgeville College. So we're trying to get, some people to go, and half the first class was from rural area and older nurses. So if, they could join together with something like this, would be really advantageous. Thank you.
Thank you. Representative Newton.
Thank you. And thank you for your presentation and your passion for taking care of women. Do you think that the department denied it because there's plenty of OB and there's not need in Augusta? Was that the reason, or was it
No.
more the model?
They actually, certificate of need actually proved there was more need than what we proved. So they said, hey,
So there is a need.
there is a
for-
need.
Okay.
Yes. So this is where my confusion lies with the certificate of need. If the need is proven, but there's one regulation that's restraining me from opening because I will not enter into, or the hospitals will not enter into a transfer agreement with me as their competition. That's what they viewed me as.
Well, you bring up a thing that I live with every day, EMTALA, Emergency
Yeah.
Medical Treatment and Labor Act. Of course, it does demand that a hospital accept a transfer. I will tell you, though, the department needing to have there's nothing that we would need to expedite more than a problem that happens during a delivery. There's nothing really,
Exactly,
very
yes.
little, even bleeding can be held with
Mhm.
pressure and tourniquets, but a hemorrhage during pregnancy or
Yes.
a complication during delivery, our EMTALA transfers, I can tell you, having received lots of them and occasionally transferred people out that needed specialty care, it can be a 2 or 3 hour process before the ambulance is called. Everybody has about 15 minutes to call you back, make a decision. you don't contest the idea that you need a hospital ready,
No.
willing and prepared and expedited and
No.
no questions asked. Is
We-
there a way we can ensure that a community benefit hospital that has the capability, forget EMTALA for a minute, just that, can we require them to accept or to at least, I mean, what do we do?
That would be lovely
Well,
if they would accept. I'll let you know that I did approach during our certificate of need process, I approached all 3 local hospitals. I in fact went up to the very top of HCA and got their head of OB for the entire country to give me guidance on what they wanted clarified for transfer, for accepting patients. They wrote everything out and it arrived on the desk of the CEO and he said, "What's the rush in signing this?" And I was blocked from there. So I had every single thing in place, and I would like it if the hospitals could view us as a partner. And in fact, birth centers bring 30% increase in profits for labor and delivery departments to any hospital they partner with.
Thank you, Mr. Chairman. Thank you for coming to talk to us today. I've got, so I'm in a rural area, so I want to piggyback onto what Scott asked you about and maybe give you the opportunity to speak more in detail about that. But first, I do have a question on the CON application process. How, from start to finish, how long did that process last for you? I know you mentioned you had over 800 pages that you submitted, but how long was the process?
It took us 3 months and it felt like 4 years.
Mhm.
So it's a very long and detailed process. For example, I can tell you the birth rate of Jenkins County in 2026. This was more detailed than any business plan that any bank would need for me. In fact, I submitted it to a bank and I could get 10 million today. That's how in detail it was. I had to provide how many women are going to be within the possibility realm of window of giving birth between the age of 14 and 60 for every single county I would serve. And that was 15 counties. So I had to provide all that information. I also had to provide funding, grants, grant writers. I had to provide so much information, and getting it done in 3 months was very difficult. And that's from the opening of the batching window. So when we asked them to open the batching window, from then we started preparing. My business partner, Kimberly Queen, wrote 32 pages overnight one night on why this area needs a birth center. We had to get letters of support. The letters of support was probably the hardest part, compiling 100 letters. It was the most letters they've ever received for a certificate of need. Getting prices. A certificate of need also required that we had to get prices from our competitors for how much they charge for labor and delivery. So you can guess how well that conversation went over at the hospital. So what we had to do is beg people to give us their bills. And that was even harder. People don't want to give over their personal information, but 5 people did. And we proved that we were going to offer an economical and lower cost birthing service. But yeah, the whole process was very long.
Okay, thanks for sticking with it. Thanks for being here to talk to us about that, because I'm interested in the process and is it efficient, but also so you've acknowledged that you need a hospital for those traumatic, unexpected situations. So would you say that it's feasible, or how would you handle coming to a rural area where there is no hospital that provides OB services? So training for the hospital.
Let's train the hospital. Let's train our staff. My staff were going to go get NICU certified just in case. They were going to go above and beyond in levels of training and care that can be provided. There's other countries in the world are doing very similar things. The UK, I come from a very rural area of the UK. They have trainings and they're able to get medical training to provide them care in rural communities enough so they can stabilize a patient to transfer. Okay. And that's an option we can definitely provide. Rural women should not be left out in this.
Agreed. Anything else you want to add to talk about rural issues at all? Just want to give her the opportunity to do that. If she, okay.
Not that I can think of.
Thank you.
Dr. Rice.
I'm going to keep us focused also, access, quality, and choice. And having done my residency training at Grady a long time ago, 10,000 deliveries a year. Access, quality, and choice really does matter. Training on the nurse midwives and physicians, and seeing how the combination of care gives women choice. Georgia has one of the highest infant and maternal mortality rates than any state in the country. And you want to bring the world in, we are not at anywhere near where we should be in providing care to women and to families. Our processes are really daunting for what you have to go through to document the need. And so thank you for that. And it is important for you to have transfer agreements beyond what we can get in EMTALA for ensuring that when you have an emergency, that hospital is ready to address the emergency. And though, we also have opportunities for training. So I shout out to the state for increasing our ability to expand our residency training program, which will include our residents training in rural settings. They will be at these smaller hospitals, understanding how to stabilize a situation that will require transfer and support to ensure that we don't end up with a maternal or an infant death. This is all about modernization, you all, of healthcare and healthcare delivery. And our certificate of need programs should be inclusive of that, of what we know. We know we have OB deserts in the state of Georgia, and we are not going to be able to meet all of those using the models that we've used in the past. Every hospital being able to do the full gamut of obstetrical care. But what we can do is create connections through training, technology, and transportation access points so that we can stabilize mothers and babies till we can get them to those tertiary care sites. And so I think we need to look at our process, and we need to understand that more in some situations is best. More access points, more access to quality care, more access to opportunities to be able to give women choice. So thank you for what you're doing. Don't give up.
Thank you. We did speak with all hospitals and had long talks about transfer agreements with them. When it came down to the business side is where they denied us. We might cut into 1% of their profit. And so that says to me that women are expendable. We're not.
Bishop, thank you for your presentation.
Thank you.
We appreciate you being here. This is the last item on our agenda, but we had asked for public comment, and we have two people who have signed up that we'd like to hear. And first of all, Nicholas Chubb.
I mean, I am related to her, but I'm not related to the Nicholas Chubb you may be more familiar with. I actually just, as public comment, I wanted to give the unique experience that I might be able to provide as one of the two people possibly in the room who have prepared a certificate of need application. So if you had more specific questions on how that system actually works, I'd like to give a little bit more elucidation on the process. And the first step of the process, since we were submitting a certificate of need application for a birthing center, it's part of what's known as the batching review. Now, a hospital doesn't have to go through batching review. You just submit your certificate of need application, and then it goes through consideration in the amount of time that that's required. In the case of Columbia County, 10 years. But if we're talking about something that goes through certificate of need, batching review, then it has to be first opened. And the decision to open it is made public by a letter to the public that goes into a newsletter that they publish on their own website. It's all public information, and you just have to go and look at it and see whether or not they're going to be open to your application. So this winter, if I wanted to, again, apply to open the Augusta Birthing Center, and they said, we're not currently accepting applications, there goes 6 more months of us not having a birthing center because they just weren't open to it. So I sent several emails to the previous executive director, Stacy Hillock, who was the executive director at the time of our application. And I asked, what's what's the process in that decision, and where you can determine that there's no need for applications for certificate of need, that there's no information about that process available at all. And she said, usually it's public outreach. And I said, what does that look like? And she said, you're doing it. So after that phone call, they published that they were, for the first time in 4 years, open to applications of birthing centers for certificate of need. Now, if you're the certificate of need modernization committee, start there. That is not modern at all. They might as well have hung it up on the door of City Hall and said, if you didn't see that, I'm sorry, you missed it. After the application was submitted, there is a protest period in which, in one of the most bizarre situations I've ever been in, I had to actually sit in on the opposition in making arguments against our application, who were 2 local hospitals, but I wasn't allowed to speak because they don't want it to be an argument or a shouting match naturally. So we had to listen to them make multiple claims about our certificate of need application and then say, thank you very much for your time. And then after that, the department actually, the best evidence I always say that we have for our certificate of need is our denial, because the denial goes section by section through the entire certificate of need law and says where you satisfied it and where you did not. And we satisfied it on the first one being need. We satisfied it in finance. We satisfied it in local outreach. We satisfied it in every single thing except for having a written transfer agreement with a hospital. We had a written transfer agreement with a maternal fetal medicine specialist who had admit rights to 3 hospitals, but we didn't have, as written, the transfer agreement with a hospital. And for that reason, we were denied. And that was our process. If you had any questions about the process.
We do. Debbie? Yeah.
Just a quick question. From the time that you submitted the application and it was denied, where are we at in that process now? How long has it been?
How long has it been since it's happened?
Correct.
2 years? Yeah. Sorry, I've had 3 kids since then. I don't know what day it is.
Yes, sir. Yes, sir. Do you think there's something, I mean, I hear this, and certainly there's no substitute for passion and the in-depth work you and your wife has done. But don't you think this could also be the case with surgeons or gynecologists, you know, young women who want to open maybe a GYN surgery center or a cardiac or some of the other things? I doubt any of them could match the passion that the previous speaker had in bringing, but I do believe there is a passion to deliver a different type of care. Maybe there's a need, maybe there's a small need, maybe there's a need for more innovation, as Dr. Rice mentioned. But do you think there's something unusual about a birthing center, or do you think that those same challenges and opportunities would apply to ASCs and other things like that?
Actually, I think you make a very good point, and you have described the exact path that we got our 3 existing birth centers in Georgia through. Up in Forsyth, Dr. Segode had originally been an OBGYN at a hospital and made the determination to go out on her own and open a local birthing center, and had the support of that hospital. And that's where her transfer agreement came from. Everything else, obviously, they had the need. It's Forsyth. They deliver babies. The second one being Savannah, which obtained their original certificate of need in the 90s. I couldn't even find it. And then we have the Atlanta Birth Center, who started inside of a hospital in a hospital-owned building, and then decided to move out from there as part of the hospital. And then eventually they started to continue their own practice outside of the hospital's purview, but still maintained their transfer agreement. That's the only way to make one now, is to start with the passion and the ability to do the job where they're at, and then strike out from there, which doesn't really help every rural community. It doesn't, if anybody wanted to open any sort of center, doctor, if you had to go through this process to open right, exactly, the orthopedics or even urgent care. If you had to go through certificate of need to open urgent care, we'd be doing way worse on the scorecard. because none of them would be open. You would have too much competition within the certificate of need system.
Thank you.
I think when you talk about how long it took you,
Yes.
you're forgetting one thing. Even if you had gotten the hospital to give you that transfer agreement,
Still have to build the
then,
thing.
then you could have had another hospital challenge. And that's where you run into the time that takes adds to it on each of these, that no matter whether you're asking for an orthopedic, freestanding center or, whatever, they go through the state approves them. And then you might right off the bat have a hospital somewhere.
I fully agree. And I think you're actually bringing up something without meaning to bring it up. But the term I would use there is a valid challenge, in which I wouldn't have any concern. None of our challenges were valid in the first place. And if you're actually opening something that there is a need for, and somebody comes along to challenge it flippantly, then that's what the certificate of need process should prevent, is that type of argumentative culture stopping things from opening. Whereas our two objections were completely baseless in the first place.
Okay, but then it gets into, they would say, your decision about valid is not mine. And when they get through going through all the state appeals, then they go to the legal system.
Correct.
Which goes on forever.
Right.
Any other comments or questions from the committee? Scott?
To Dr. Rice's point earlier, as we talk about the desert that exists, while we may have an OB desert in areas of the state, maternal fetal medicine exists as well. We can deliver all the babies we want, but the need to be able to provide maternal and fetal medicine care, probably in a creative way, is equally a void. So that's more editorializing than a question, but a question about the centers that exist today. Are you open 24/7, 365?
That is the intention.
Okay.
We're not open now because.
Yep.
Well,
Got it.
Okay.
Thank you.
Thank you very much.
thank you very much for your time.
Next on our list, Jamie Kavanaugh, and that'll be the last speaker.
Good morning. I'll be brief. I'm the last speaker, but I just wanted to address a couple points that we heard today, especially about rural healthcare as you're considering what recommendations you might make to the full General Assembly. We heard about the North Carolina reforms that were passed this year. And while it's true, it's going to take a couple years for them to kick in for counties with above 125,000 for ambulatory surgical centers. They actually already applied today for rural counties. So an ASC can go into a rural county under 125,000 and open today because my law firm, public interest law firm, is representing a ophthalmologist there who has a surgery center built and cannot get a certificate of need to use it, where he could offer lower cost procedures for his patients. And his county, unfortunately, is just slightly bigger than 125,000. So he still doesn't qualify for that new reform and is still, trying to wait to help serve his patients. So while it's true that in some places there are exceptions that keep certificate of need laws in place for rural areas, actually what we see more often is the opposite. Alabama, Kentucky, Oregon, Washington all have substantial carve-outs for certificate of need in rural areas. They still have certificate of need programs and laws in their state. Kentucky and Alabama especially very robust. Actually, all those states very robust, but they specifically, allow rural hospitals to open without first going through the certificate of need program. And Tennessee, in its recent reforms in 2021, also made it possible for critical access hospitals to reopen without going through this burdensome certificate of need program. And the last thing I want to say is just that we heard from Mr. and Mrs. Chubb, and really that's the perfect example of the type of innovation that all Georgians are losing out on. Thankfully, they're here today fighting, and they're still trying to open their birthing center, but a lot of people hear about the requirements, get discouraged when the first time they talk to a lawyer, and they don't bother applying at all, or they go to another state, they go to South Carolina, which just repealed CON, they go to Florida that has repealed CON and have more opportunities. So the lost opportunities add up over time. That's why we saw the states with certificate of need at such a disadvantage during the pandemic. They were 27% more likely to run out of hospital beds. Even if they did some temporary waivers of certificate of need programs, that made no difference in the numbers about whether or not they would have a shortage of hospital beds. So that just shows kind of how the decades of having these programs in place has really held back states that are still using them. So thank you. I'm happy to answer questions if anyone has any questions.
Dr. Rice.
During the pandemic, did we see an increase at all nationwide of hospitals being open that were on waiting lists for certificate of needs? Did we see any type of increase approvals? And then hospitals actually being able, our ambulatory surgical centers or other type of entities that required CONs being open during the pandemic, and did that make a difference when we relaxed some of the laws?
That's a great question. Most of the states that relaxed their certificate of need laws just allowed existing hospitals to add beds without going through the certificate of need process. And that was actually just a temporary process. So, or, they could also add equipment usually and do other things. But once the official executive order for the state of emergency ended, then they had to usually give up those things that they had added during the pandemic.
Thank you. And you mentioned that in rural areas, maybe in Alabama, you may have mentioned that there is that CON does not apply. Is that what you said? Or
for rural hospitals, yes.
Okay, because I can see a difference just when I look at rural areas, and if someone wants to come in and build a full-fledged, fully equipped hospital, I could see why you wouldn't want to stop a brand new hospital being built next to an older one who may oppose that hospital if they're going to offer all the same services. There is a little question a lot of people have with fairness. It's not a level playing field. If somebody just comes in and opens something that attracts the typically insured patients, or it attracts the higher paying things without, once again, dealing with the complications, the requirement to keep an ICU, an emergency department, an operating room fully staffed 24/7, a blood bank, everything that's needed to handle complications. How do you deal with the fact in a rural area, while you might not mind a new hospital, a full hospital being built because it's going to offer all those things? How do you address the cherry picking idea of people on the inside, like some of us in healthcare who know where money is made, of just wanting to put those there, take that business out of the local hospital. Somebody else takes another part out of the local hospital, somebody else takes, and then you're left with a shell that is not sustainable. Is there a way we can address CON that still allows a prevention of cherry picking, if that's the way to put it?
Well, that's a great question. And, maybe how the law is written in those states, allowing hospitals to open is to address that. However, I would say that the evidence actually shows there are more hospitals per capita, more rural hospitals per capita, more surgery centers per capita, more rural surgery centers per capita in states without certificate of need. So when you get rid of certificate of need, there is a proliferation of surgery centers, but it's not putting hospitals out of business. In fact, everyone is doing better. There's more of everything. So the data in the real world, what we know, what we can look at our fellow states, Texas, California, Pennsylvania, all these states, and we can see that there are more hospitals available per capita. And they've studied that separately for rural populations specifically.
Thank you.
Okay. Didn't one of the presenters say that in one of the states, or somebody that did away with CON, that 90% or a huge percentage of the opening of surgical centers was in the urban areas?
Yes.
Is that
that was in Florida?
The trend? They really don't go to the rural areas.
There was one so far that has opened in a rural area in Florida. That's what the research showed. Yes.
Oh.
Thank you.
That completes our agenda, as well as those who signed up that wanted to be heard. We've done that. Is anyone on the committee have any more comments or questions they'd like to pose at this time before we adjourn? Okay, well then let me say thank you to all those who presented for us today. I think we got a lot of good information and brought along a lot of discussions and give us a lot to be thinking about as we move forward. I want to thank the committee members for being here today and also our friends in the audience who are interested and visited with us today. And a special thanks to our friends over at Augusta University for hosting us today and making this all possible. Just want to remind you that our third meeting will be in Albany, September the 12th. So be sure and put that on your calendar if you have an interest. And with that being said, we'll adjourn our meeting. Thank you all for being here.